is in place and we can trust on the our initiation protocols, then only we have to proceed. So consistent treatment delivery. Immobilization devices allow for accurate setup during each treatment sessions. It is not only the day one or day two, but every day we have to take images when if we are going for the high-end treatments, ensuring that the radiation is delivered to the same area each time. This is especially important in fractionated radiotherapy, where multiple fractions are given over a period of time. If we are going to take the image on the day one or day two, and then after a weekly, that we don't know what is happening in between the treatments. So it is very essential that if we are wants the precision, that we should go for daily imaging. And so if we are going to daily imaging, that immobilization minimizes the day-to-day variations in patient positioning, reducing the risk of treatment errors, and improving the overall effectiveness of the treatments. That overall the effective of the treatments means the clinical output, that what our intentions is, what we have thought before planning this uh, delivering the radiations. So the outcome will be that the clinical outcome will be good. And the fourth is ensuring the patient comfort and compliance. Because while some immobilization devices can be uncomfortable to the patients, but at the same time, they are very essential for achieving our required precision. So, but the patients are not sometimes cooperative. So addressing potential patients are anxiety. There are some patients, those who are the claustrophobia related issues. Those things can be explained through education and through coping strategies. That means that before recruiting the patient for radiotherapy, we should have a good consultation. We should have an initial consultation with the patients, tell about their do's and don't do's, and what are we are going to do, and provide the the information about the treatments so that he or she can read, and involve the relatives or sometimes the translator into communications. So we have to do a very effective communication, and maybe we need the help of the psychologist also. That those patients who have the claustrophobias and who are not cooperative, we can involve their role also. So improving patient experience by reducing movements and promoting a sense of stability, immobilization can make the treatment process more comfortable and manageable for the patients. So these two things can be through effective communication. These things can be achieved. Now, the fifth one is the minimizing the normal tissues, which we have discussed. That if we have a good precision treatment using the imaging techniques, we can spare the healthy organ at risks and healthy tissues, and like the parotid glands, which produce saliva and are vital for the oral functions. These reduce the side effects like xerostomia, that means dryness of the mouth, difficulty in the swallowing. There are taste changes in this and limited mouth opening. These side effects can be reduced by the precision of the radiotherapy, if we have achieved our precision. Now, even if these we have why it is important, but we have certain challenges also in the head and neck mobilization. One, which I have discussed, that the patient discomfort and anxiety because of the closed mask, and some patients are not cooperative, and there are issues with socio-economical issues also. So we have to, the other person, that the mask can be uncomfortable to wear for the duration of the treatment. And these issues can be addressed, that if we provide the full knowledge, not a limited information. We should, the patient education material should be provided, and patient education, that pamphlets can be given to the patients, or through the video this can be provided and displayed in the OPDs areas, where the patient can watch these videos, that what are the issues and how we are going to tackle with these coping issues. And fourth one is that position accuracy and reproducibility. Anatomical movements, the head and neck regions, highly mobile, and achieving consistent positioning from one treatment to another position, another fraction to be the next can be challenging. So what I mean to say that it is very difficult for RTTs that if we are able to achieve the position on day one, it is not, we can't achieve the same position on the day two. So that's why that immobilization should be such that it should be reproduce the patient setup as well as exploit our imaging tools. And despite this fifth one is systematical and random errors. Despite immobilization, patients can experience setup errors, include shifts in translation and rotational errors. These variations can be due to the patient movement, setup inaccuracy, and limitation in the accuracy of the immobilization system. That means these setup errors and random errors not only due to the setup, but the patient is not cooperative. It can also be the issues. Patient can move during the treatments. It can also be the issue. Or our RTTs, they are just randomly setting the patients. It can be also the issues. So we have to when setting the patients, we have to follow certain protocols, certain guidelines to address these issues. And it has been observed that lower neck areas, where right from the shoulders, because shoulder movement is such that he can push the shoulder up and push the shoulder down. So studies showed that the lower neck immobilization needs further development to reduce the population errors with greater challenge than not using the mask. So in some of the cases, some of the centers, they are using the mask, not restricting the shoulder area. And some centers, they use the shoulder retractors, but it is very difficult to reproduce the same position with the shoulder retractors, because now it is not in the use, but some of the centers still are using, and it is very challenging for the lower neck mobility. So impact of the anatomical changes. Weight loss is one of the issues, and tissue edema during treatment can alter patient's anatomy, affecting dose calculation, and requires the adaptive radiotherapy. So weight loss, definitely we have to go for adaptive radiotherapy, which you are going to discuss in that future slides. So internal structures like the tongue, jaw requires additional consideration for immobilization, often involving customized oral stem cell bite blocks. So during treatment, the tongue can move. It is also one of the issues, and particularly in the vocal cord, that patient swallows a lot of times while the vocal cord moves from one place to another place, and we don't know how much dose has the patient received. Even if we have taken the image and we have found that the setup error is correct, but actually during the delivery we don't know. So we have to tell the patients not to swallow during the treatment. We have to give the proper instructions on daily basis to restrict our this vocal cord movement or tongue movement. And if there is a motion during the treatment, and there will be the dosing difficulties which has to be addressed. And internal immobilization, that we have different immobilization devices and techniques, such as some of the immobilization which are not MRI compatible, but still we are using it for fusion purposes. So we need to do the for fusion purposes. We should have this immobilization which are MRI compatible. And lack of standardization, that means there is no proper, that if one center is using one immobilization, the other center is using different immobilization from different vendors, we can't compare the data. So this is one of the issues at the national level, at the state levels. So we need to address those issues also. So where we can have proper the protocols, and we can have some internal audits among the hospitals. So addressing the challenges, one of the improved immobilization systems. So we have to, there's development of more comfortable and accurate immobilization systems, such as the double shell positioning system. We call it DSPS, and customized headrests with mouth guards can improve the alignment and accuracy of the system. So some of the emojis which are existing, if we feel we should not allow in our system to be continuously used, then our goal is not achieved. Patient education, provide comprehensive patient education material and psychological support can be help them manage the anxiety and improve the patient compliance and treatment adherence. So image guidance and using daily CBCT or other image modalities like the exact track imaging, surface guidance, stereoscopic X-rays or 2D X-rays, it can also help. In short, daily imaging has to be done. So by addressing these challenges through improved immobilization techniques, quality assurance, and patient support, it's possible to enhance the accuracy, safety, and effectiveness of the head and radiotherapy. Now, some of the guidelines when the patient enters in the hospital, all registered, they have to register. So all registered patient needs to undergo a detailed clinical assessment that we call the initial assessment with the radiation oncologists. And if possible, on the next visit, the radiation oncologists take all the persons who are involved in the treatment, a medical physicist, dosimetrist, radiotherapy technologists, and I also encourage the oncology nurse also should be involved in the treatments, because in some of the cases we need her help because of some of the patients who have the tracheostomy patients and they need the oxygen support. So we should involve the oncology nurse also. Counseling by the treating physician regarding the treatment related preparations. That means what we are going to do, we should have even starting with the scratching, like we have to undress the upper portion for making the cast. We have to tell them directly and give these pamphlets or information materials so that they can read at home and come back preparation. If they have queries, next day we can explain them fully. That one of the more important things, the informed consent is obtained from the patient's family if required the help of the interpreter. Patient with beard should trim or shave it off. Now, few of the things I have just in the presentation, but I have some more points. That means the patient with the long hair, they are again the challenging, and some which we have faced at our center, that is the patients with the crown row here. That's in the African patients, because we are getting from the Nigeria and other Chechnya patients. They have hairs, they make the artificial hairs tied, and it gives a very listen that we have to tell them that you have to remove those artificial hairs, and then only we go for treatment. This one, that crown row here we call it. Inform your patient. Then there's a tracheostomy patient. That is also the issue. We have to address those issues, and then we have to inform your patient that shaving can irritate the skin. We have to give the instructions. So during the radiotherapy, they should use the electric shaver. And there are so many guidelines which we can't discuss here, but so many which we have protocols at our center. If your patient experiences any discomfort or pressure, claustrophobia or anxiety, it's very important to comfort them. And if required, he or she should be counseled by the psychologist, clinical psychologist in the oncology department we have available. So we send the patient on. Now moving to the other sentence, the other slide is a dental consultation. It's a very important. In head and neck case, whether he needs this dental treatment or not, but it is mandatory that we should send every patient to the dentist to have his consent, and if anything has to be done, it has to be done before starting the treatment, because after we start the treatments, we can't do any procedure. Next, for we can say 10 to 12 months, we can't do any extraction or any surgery for the dental things. So note that anything decision has to be there, should not be delay in the treatment, as because the cancer is progressing. And after, if there is an extraction, it must be done immediately. And after extraction, after 2 weeks, we can start the radiotherapy. 2 or 18 days, 17, 18 days, we start the treatment. Now, detailed explanation of the procedure. So, in head and neck cases, we have to explain the patient about everything based on the tumor location and the treatment protocols. What thermoplast mask we have to make, because there are three. This is one is 3.3 clamp head mask, then 4 or 5 clamp head and mask. The first one is only for the brain, and this is for the head and neck. And this is we are using for stereotactic radiotherapy. We call it the SRS. And now the mostly what we at our center are using thermoplastic mask. The material is caprolactone, we call it a PCL, and it's a biodegradable polyester commonly used in thermoplastic masks. And it can be dipped in the water. The temperature should be between 60 to 70 degree, and mostly we keep at between 68 to 70 degree at our center. And it hardens. It takes 3 to 4 minutes to harden, and then almost another 8 minutes to take the proper shape. So at our center, we are using the 4 mask, and also 5 clamp mask, you can see, and also with this S-type mask. Just S-type mask is the best mask, because it covers the vertex area also. That's we are using, and there are different head masks. That is D-clamp, and that is U-shaped, and this is frameless mask. So now there are different headrests. We are low density headrests. This is the indexed board and prone headrests. But now we are not using. Almost 15 years back, we used to use the prone mask, but we are now using. And these are the indexing bars you can see below. And if there is a gap between head and head neck, so we have the other accessories, different thicknesses. This is carbon fiber base plates from Orchid Industries. So we are using that one. The mouth bite, it is one of the essential things, not all patients, but in some of the patients we need it. Improve positioning accuracy, reduces radiation dose to healthy tissues, helps in tongue displacement or oral cavity sparing, is a non-invasive, and but it requires cooperation from the patient. So it is how we do it. This is the dental wax. We in a hot water, this kidney tray, we put a hot water and immerse this dental wax it, and we are using the spatula and put this. Once it is cooled down, it will be its form. And this is the frame molds. Different frame molds. We have 3 frame molds. First upper one, and this one is from the Brain Lab, and this is for the quick fix, and different indexing boards are there. So steps involved in the head and neck radiotherapy. There are so many steps. What's the aim of the radiotherapy? Patient immobilization, CT planning to adaptive planning, online, offline. Means so many things are involved in the steps. We are going to discuss one by one. So we at our center. So the primary aim of radiotherapy is to deliver the desired radiation dose accurately to the desired target volume for the treatment. This is our aim. So we are taking the image for the head and neck is between 1 mm to 3 mm. 1 mm for the SRS. Otherwise, we are taking 2 to 3 mm for normal IGRT cases. And this is how the plan is generated on the this to deal with the treatment uncertainties. This setup errors margins are generally added to the target volume. So the goal is to deliver the maximum dose to the target, sparing the health. So these are the imaging CBCT, KV, KVMV, and etc. imaging system which we are using at our center. So, but the KVMV it doesn't is fit for the 6D coach. So mostly. No, no, most of the time we are using CBCT and exact. So now adaptive radiotherapy, because in head and neck cases we need adaptive radiotherapy. So adaptive radiotherapy is the approach to correct the daily tumor and normal tissue variations through online or offline in image modifications of original treatment and target organs. Sometimes during radiotherapy we take the image, we proceed for the treatment, we see everything, but at the same time we see that there is a gap between cast and the skin due to the weight loss or due to another reason. We go for treatment, but we inform the concern that oncologist to take the necessary steps, and we check the offline, and the decision is taken whether we should wait for 1 or 2 days more, or whether we should go for adaptive radiotherapy. So need for adaptive radiotherapy when it is a change in the daily setup, and there is a change in the daily setup, not because only the weight loss, daily setup, and the tumor has shrunk, also the change in the tumor and change in the anatomy also. So the fact there could be a lot of factors. This could be nutrition and weight loss, skin and mucosal reactions can also, because sometimes the reactions are too that causes weight. There is no weight loss, but reactions are too high. So we have to see the dosimetric. Why is the dosimetric uncertainties in here? And change in the anatomy, particularly in the carotid region, regression of the tumor, and regression and aggression of the tumor. So sometimes the tumor is not responding, so we may need also adaptive radiotherapy. Post-operative collections and air bubbles, setup variations due to mobilization devices tight or loose, fast. So image show variation in the patient body, volume and dose distribution between treatment plans, pramidine plans, CT without change. You can see that after 34 days, there's a change in the little bit plan. We'll look very carefully, there is a change. And in this case of head and neck, this you can see the optic chiasma is very close. So in this case, we have to take the daily CBCT. Otherwise, if we won't this, we are going to eradicate this optic chiasma. So we have to be very careful. Now, this is what are the unique cases? Simulated with the tilted head position. You can see that one, tilted head position due to pain and disease side. So replant after 14 fractions, once he was relieved from the pain, he was relieved from it, then you can see that straight his neck. Initial position was the tilted neck, so it was straight neck. So there was no option to continue for this and making daily change in the it's a compromised treatment, then we can say. So we have gone for the adopted radiotherapy. And here you can see this. The first one is the primary CT, and after CBCT, after 18 fraction CBCT, there's a weight loss in the medial region and neck region also. So weight loss was 6 kg. So after radiation, 18 radiation, we went for adopted radiotherapy. You can see. Okay, so there replant after 19 fraction, GTO generally regressed. You can say there's a regression of this tumor. There's an air gap also in the initial CT, and now decreased air gap. So better to go for adopted radiotherapy. Now this is the overall 7 kg loss. First replant 16 fractions, you can see here, and then after 22nd fractions, there was a weight loss. You can say that firstly it was 7 kg, then 8 kgs. So, change in the neck curvature. Now, this is again during the planning. You can see this is a tilted neck because the patient was stressed. He kept his neck too much extended when the treatment started, and day 2 he was comfortable on the treatment coach. Now it was a straight neck. There is no option to go for a plan. So this is the tilted neck. Again, here you can see now the straight neck, go for a plan. Now this is one thing. Target volume increases. This is the initial CT. This is one that after 2 weeks treatment, instead of the regression, tumor has increased the aggressive tumor. So we have to see that dose levels, dose delivery has to be changed, and we went for adaptive. Now you can see the anatomical change. This is a parotid region, and this is the this tumor site. Now what will happen is that parotid region that it has reduced it to go for adaptive radiation. So now there are all mucosites in the inflammation of the mucous membranes in the mouth. You can see the dry mouth and pain and so many reactions. So we have to see the what are the dosimetry of this patient and see why the reactions are so high. So we need to discuss and with the radiation oncologist and medical physicians, whatever the decision to be made has to be taken immediately. Now, this was the head and neck. Now we come to the SRS. As we know Dr. Lars Lackelson, along with the physicist, radiobiologist, Borji Larson, they developed this and 1960s. They called this Dr. Laxon called the technique as a SRS technique, and this just 2-3 minutes. So instead of invading the patient's brain or body via incision, SRS delivers high intensity radiation specific location. Initial SRS treatment was defined as a single fraction of radiation delivery. So newer techniques came, and then we shifted from the frame-based the view frame, then the frameless. This is the frameless. So frameless is easier for the patient, for the physician, flexible, faster, accurate, and check possibly in our course directions can be fractionated if necessary. So this is the how we shifted from the frame to frame. So what is Isrrt-Rtt? High confocal radiation beams are used to deliver high dose per fraction for targeting the well-defined tumor. SRS combines advanced hardware and software also treat tumors, vascular malfunctions, and other also other functional disorders. Is a non-invasive outpatient procedure. So in stereotactic, so we if it is a single is a stereotactic, we call it SRS, is a single fraction. FSRs means fractionated stereotactic fraction, it is 5 to 8 fractions, and SRT means delivered in a number of fractions, 25 to 30 fractions. So then what is the goal of this fraction? That is the stereotactic reversing positioning and reduce the margins around the target. To achieve these goals, multiple convergent and non-coplanar beams are used. Is a rapid dose follow-up outside the targets and confirmatory prescribers would get the volume. So where it is recommended, it is the tumor should be less than or equal to 4. We're not discussing this one. And alternative treatment for patients with the inoperable condition where we can't have the surgeries, we can go for it. And SRS requires special equipments with hardware and software, and there should be well-trained professionals. It should not be that anybody can do it. We should have an understanding what is the SRS. And these are some of the procedures what we have to do, this immobilization to treatment. And this is the Novalis TX, which we have we used the infrared tracking, and now we have the edge exact track dynamic, which I have not shown in this slide. So during this, we take the this one exact track imaging. After that, apply the setup corrections and verify with the CBCT. If everything is okay, then we proceed for the treatment. And during this treatment, we take a snap verification to see that our center, our treatment center is within the 1 mm accuracy. Then only we proceed for the treatment. If it is not, then we take one more exact track imaging to proceed for the treatment to keep our treatment accuracy within 1 mm. So these are the, I have done a study of this randomly picked of SRS, FSRS, and SRT. 75 patients for each site, and setup margins were very within the tolerance level. Only one patient in SRT was 5 mm pitch value. You can see downstairs. The weight of the patient was 160 kgs. So there was always, when he lied on, the pitch was, so we don't have any options, but we managed to somehow treat. So these are the cases, 4 cases are just the CA breast, lung, and liver mets diagnosed in August 2000, and developed brain mets in 2018. SRS to a dose of 20 and 22 day, 2 lesions we have treated same day, uh, the 2 lesions together. And this is the 4 lesions in then the same patient, 4 lesions July 2018. So SRS dose 22, 4 lesions we treated. You can see 1 lesion, 2 lesion, 3 lesion, same time at the same time. Then case 2, 74-year-old male, metastatic esophagus, received chemo, and this one, and developed brain metastasis in January 2018. SRS dose at 22 grain, 22, 2 lesions. You can see the lesion 1 was bigger one, lesion 2 was lesser. We treated simultaneously. And single new lesion, another lesion was we treated with 20 gray. It was also bigger lesion. And case 3, it is a pituitary SRT case. Just show that we have to be careful during the treatment and treatment. And this is the case for 30-year-old male. Case of a lung developed brain mets 2017 and SRS 18 gray and 22 gray, 8 lesions. We treated simultaneously. See this, both cases, this one. And in conclusion, so timely actions such as replanning have brought down the such errors. With exact image verification followed by CBCT image, we can achieve treatment accuracy within plus minus 1 mm. As SR is a complex treatment, so to achieve high level of accuracy in dose delivery, we need follow QA procedures and processing, which is essential for SRS treatments before treatment. Thank you very much.
Thank you, Rakesh, for this very insightful sharing. Unfortunately, due to time constraint, we will not be able to have any questions now. Thank you so much. Thank you. Let's invite our second speakers for today's session. Our second speaker is Mr. Ho Kwan Ta from the National University Cancer Institute, Singapore. And today he'll be presenting on developing the role of head and neck advanced practice radiation therapies, sharing on the ANSYS experience. So let us welcome Mr. Ho Kwan Ta.
Having me here today. My name is Ho Kwan Ta. I'm a senior radiation therapist at the National University Cancer Institute, Singapore. And I'm honored to be an invited speaker to present my topic, developing the role of head and neck advanced practice in ANSYS hospital. So this is my disclosure. So this is what I'm trying to present today, my outline, some background from where I came from, the training that I received, how we develop the role of head and neck APRT, and maybe some pointers that I've come to in my journey. So this is ANSYS. This whole area is the hospital, and this is the Cancer Institute. So some background of my hospital. In ANSYS, we have 4 linear accelerator and 1 brachy afterloader. So of the 4 linear accelerator, we have 3 variant and 1 elector. We have 2 CT simulation machine, and our annual patient load is about 2,000. So we have another site that we are also supporting, which is the Tan Tock Seng Hospital, and they have 2 variant machine as well, 1 CT simulator, and they are treating about 1,000 patients every year. So maybe some definition of what is advanced practice. So this is all from Google. You can Google it. So I extracted some definition from the different society around the world that have been practicing this advanced practice role for the past 20 plus years. So the first one is actually from UK, the Society of Radiographer. So they define as the practitioner as developed expert knowledge and skills in relation to the delivery of care in the diagnostic imaging or radiotherapy. For the Canadians in the Canadian Association of Medical Radiation Technology, the definition is the advanced practice in medical radiation technology is defined as a higher level of practice wherein clinical responsibility routinely exceed the current principal expectation of practice. And lastly, we have the Australians. So the Australian is Society of Medical Imaging and Radiotherapy. The definition of advanced practice radiation therapist is a practitioner that demonstrates expertise across the different dimensions of practice and is able to provide the evidence of their advanced capability in each dimension. So we'll just go through some of the trainings that I received in my development of this role. So how we come to decide what the training is to actually identify how do we want to train the person, which is me, and what do we want the person to be involved. And obviously, this is the diagram where I show that where all the touch point that the radiation therapists can be involved in the patient journey, all the way from consultation to simulation to planning to treatment and also treatment review. So we want the advanced practice person to be trained in a multifaceted aspect of it, meaning we will have on-the-job training, we also have job shadowing, and also some curriculums. So I'm very fortunate to actually be able to go to a few centers where they have actually developed the role for the past 10 to 20 years. So the first one is at the Princess Margaret Center all the way on your left. There I met a very friendly bunch of Canadians, and they are very excited to show us for the past 25 years how have they developed the role. At the same time, when I'm there, they also allow me to, or they organize for me to go to another center, Jurembowski Hospital, also in Toronto, where another advanced practice head and neck radiation therapist does the role differently from the Princess Margaret Center. And of course, lastly, in Singapore, actually, in the National Cancer Center, I have my good friend Sin, who has been doing advanced practice role in head and neck for the past 10 to 12 years as well. So I managed to get the time to go and learn from her. So this is just a summary of what I have found out from my visit to the different center, and also talk and learn from the different experts what is their role and how it differs from one another. So from Princess Margaret Center, the head and neck advanced practice RT actually is more like a planner, a dosimetrist. So he's more involved in the contouring of the plan, and then he developed processes such as dose of the day to do some form of adaptive. And also he is the gold standard for the AI to learn from his contour for the head and neck plans. In Jurembowski Hospital, the head and neck APRT does not do contouring. It's more involved with the clinical work and also the treatment review. So she gets consulted, of course, on the floor if there's any technical help needed for the therapist. And also she's seeing the patient for the first visit when the patient is diagnosed with cancer, and he's already discussed that radiation therapy is part of the treatment plan. So she will be the first line of consult for the patient, will jot down all the patient detail, and then the doctor will come in and see and then complement on the treatment review itself. So lastly, at NCCS, Sin actually does a lot of head and neck imaging approval instead of the radiation oncologist. So she's given the autonomy and the credential to do that. And then she also does the treatment review for the patient as well, using the CTCAE scoring. And then she works, because in National Cancer Center, they have proton as well. So they do treat head and neck patients with proton therapy, and she is also the technical expertise for both proton and photon therapy for head and neck treatment. So as you can see, all three of them, even though they are all called advanced practice head and neck radiation therapies, but they all perform different roles in their hospital respectively. So what is very important if you want to develop this role is to identify the gaps or the problem that you see in your hospital. So these are the few areas that we have discussed in my team for my hospital. For example, in consultation, after the patient has been discussed at the multidisciplinary tumor board, we can make sure that the referral gets to the radiation department and there's no miss or lapse in the timely referral for this patient. We also can help with the coordination between chemotherapy and radiation therapy because we know that for head and neck, the treatment plan is always very complex. A lot of time there is a lot of concurrent or induction chemotherapy that's involved with the treatment regime of the patient. And all this is very systematic, but also very complicated at the same time. So it's very important that the patient do not have lapse those referral and treatment. In the pre-treatment, we can also help to make sure that all the diagnostic images are done for the patient. If not, we can ask the doctor to refer them, make sure that we have all the PET imaging, the MRI imaging, and the CT scans. And also, maybe we can also help to refurbish or update the CT protocol for the head and neck patient because all this new technology and all the new immobilization devices, sometimes the thing you do last time is not applicable now. So there's always an opportunity to update and upgrade what we have. Obviously, at planning processes like what the Princess Margaret advanced practice head and neck person did, we can be expert in the contouring. So the doctors can just contour the PTV or the CTV, and the rest is all done by this advanced practice role. So in treatment, like what Sin is doing, we can be the expert of the imaging. We can set the imaging protocol, and also based on this imaging, we can refer to some form of adaptive. Let the doctor know that this is time now for the patient to go for a resimulation, so that we can have more better, conformal, and up-to-date plan for the patient. And we can also help the doctor to manage the side effect of the patient during the treatment, like what the Jurembowski head and neck APRT. And lastly, at the follow-up, we can also be involved with long-term follow-up for the patient that's coming back for treatment review. There's also talk about referring to other professions such as speech therapists, because we know that head and neck patients, they suffer a lot of side effects, especially at the swallowing, talking, and all that. So all this affects the quality of life for the head and neck patient. And with a timely referral from us to other allied health professions, such as the speech therapists, we can help to improve the quality of life for these patients. Lastly, I'm not sure whether there is a patient support group but in NCIS, we have a patient support group where patients that have gone through the treatment come back and talk to those that are going to start the treatment, share with them their journey, also ask and also hold their hand through these difficult 33 sessions of treatment. So these are the roles that is expected of me or whoever that's doing the advanced practice role in our center. So we have the clinical role, where the person is still supposed to maintain the competency and the clinical practice of the treatment or the simulation, depending on which area you are going to be expert in. Then we are also supposed to be involved with research, where you're supposed to engage and collaborate in original and translational research for new treatment initiatives, such as if you have new equipment coming in or you have new mobilization devices, you can do some form of research to make sure that these new things are used properly. The next one will be teaching. So something like now, I'm teaching or sharing my role for educational purposes and for staff, undergrad or overseas course. And then lastly is to administer or to incorporate the protocol or new protocols into the department, such that we are always up to date to the latest treatment processes. Okay, so now I'm just going to talk about how I have developed my role. So my role consists of two parts for now. One is imaging and one is treatment review. But today we are just going to talk about treatment, the imaging part. So in the imaging part, I have sort of been involved or done 3 different projects. So on the bottom left, we have the traffic protocol. In the middle, I've done a study with the head and neck radiation oncologist to accredit myself. I'll explain it further. And then the last one is something on adaptive or AI, where we are doing some form of deformable registration for patient who has lost weight for head and neck treatment. So all these studies is actually involved in the different part of your imaging processes. So after you have taken your cone beam, you need to verify and make sure that this cone beam is good, the position is good, and the soft tissue or the image is still a valid one. And then ultimately, you need to make a decision whether is there a need to do a replan or and the arrow just shows like how the different project is involved in the different part of the imaging processes. So I'm just going to touch on the first one, the traffic light protocol. So this traffic light protocol is not new. We did not invent it. We just adapted from other centers. So it's just like your normal traffic light you see on the street. You have the red, the amber, and the green. So very simply, you start by positioning the patient. You take your cone beam, and after that, you do your image matching. So everyone is doing the same thing now. So next, you need to make sure that whether is your matching good. So if you're matching good, everything matches, you are in the green zone. Right? You're in the green zone. So you continue to treat your patient. So that is the simple one. So next, the amber. What do you mean by amber? Amber means that something is wrong with your image. Not exactly perfect, but not very far off either. So you may not be able to make that decision. And normally in our department, the decision is to be made by the radiation oncologist. And what do? We will still continue to treat the patient, but we will alert the radiation oncologist to review the cone beam, and then we will document in the system to say that we have done that. What the doctor is supposed to do is to reply our query in the next 2 days. Okay, and whether there is a need to just continue the treatment, or we need to increase the frequency of the cone beam, or do we need to replan for the patient, or we just need to stop the treatment immediately. Okay, lastly, the red one means that the matching is totally off. You should not even proceed with treatment for the day itself. You should inform the radiation oncologist immediately, and then the doctor will also again give us the decision which one to follow. So this is the guideline that we have for the radiation therapist that is doing the treatment on the ground. So this is a table for them to refer, and then we have some numbers or figures for them so that it's easier for them to be systematic in the way they review the cone beam. So for example, the amber alert, if the tumor is on the first row, the expansion of the GTV is within 3 mm of the PTV is on the amber. It is still within the PTV, but it's growing very close to the edge, and you're afraid that you are going to miss the treatment. So you can still continue the treatment, but you need to alert the doctor, and the doctor will need to make the decision whether is this still adequate and whether he or she is still confident. So, for example, things that you should not do or you should stop the treatment immediately will be, for example, if the PTV is already out of your PTV expansion. So all your margin expansion is already busted, gone beyond. You should not even treat the patient because you do not know what is the actual dose that is going to go to your main PTV or main GTV, and that will actually cause a very detrimental treatment outcome for you. So this is just an example. You can find this online with a lot of different hospitals. They use roughly the same thing. So next, we'll talk about the concordant study that I'm doing with my head and neck radiation oncologist. So the aim of this study is to validate myself to improve the cone beam image without the radiation oncologist. That's like what Sin is doing in the National Cancer Center Singapore. So what we do is we compare my matching of the cone beam with 5 head and neck radiation oncologists, and in total we are doing 25 patients. So about 125 images to review. And the endpoint is for me to review all the head and neck cone beams radiation oncologists, and by doing so, it allows me to provide timely advice to the treatment floor RTs if there's any deviation or the matching that I feel that can be improved, and also if there's any need for me to escalate to the doctor in a more quicker manner. Okay, and then ultimately whether we can proceed further by giving me the decision to request for the patient to go for a resim based on the image that I've seen that is not suitable for the treatment arrangement. So lastly, I'll just talk about the deformable barrier registration that we are doing for our head and neck patients. So we aim to provide quantitative data of the control of the dose coverage for the head and neck doctors based on the changes that are seen during the cone beam so that they can make better decisions. So if you remember just now at the traffic light portion, is just all a standard template. There is no information given to the doctor. The doctor is supposed to review the cone beam itself. And to be honest, sometimes the doctor's decision and our decision pretty similar. It's all guesswork. Nobody knows what is going on inside the patient body based on the work. So what we do is we want to generate or to create a synthetic or adapted cone beam based using this program called the velocity. And then we will provide some statistics or decision matrix for the head and neck doctors. And all this is supposed to be part of my workflow that I showed you earlier, where the doctor is supposed to give us the decision within the 48 hours. We will provide them with the information within 24 hours. So they have time to review the extra information, still make the decision in a timely fashion. So we plan to integrate this into the traffic light protocol. We want to ultimately shorten the Amber Alert from 48 hours to 24 hours. And then we want to make this a self-driving thing. So the floor can actually raise up to say that I want to get this done so that the doctor can action. So this is an example of what we are showing the doctor. So if you can see, this is the original contour for the patient. So this is actually the left parotid and the right parotid. So what I'm showing you now is that after the patient lost weight and shrink down, you will find that there's a lot of change in your parotid gland volume. Hence, the amount of dose that's given to your parotid will change also. So this is just one example of what the doctor will see based on the new contours that we will generate for the doctor without going through a resimulation. All these are done based on the cone beam that is taken for the patient on a daily basis. Next, we will generate the dosimetric statistics for the doctor. These are things that we generate on the daily basis already. So all the head and neck with all the plans for us will have these dose statistics for the doctor. So on your left is the original one, where you see most of them are green. There are some red, which the doctor have already noted. On the right, you can see that this is the estimated changes in the new dose. So you can tell, even though I show you the parotid has shrank a lot, maybe the PTB has shrank a lot, but actually the coverage of the PTB 70, the first row, the one that highlight green, it is still good. So the main thing that you are trying to target is still good. What is the problem for this new shrinkage is the rest, where it's a lower dose. So the doctor, you can see some of them are supposed to be green, now change to red, which is part of the guideline or the protocol. So what the decision that the doctor needs to make is that, is this going to affect the outcome of the patient? Is this important? Or is the first one the most important? And then this is not as important. He is able to accept the changes and we can still continue the treatment. So it doesn't mean that when we do this, we need to do a resimulation. It means that the doctor has more information in making that decision, and the decision will be more accurate based on the information that we give the doctors. So in conclusion, some learning journey pointers that I've learned in my 1.5 years doing this role is that you want to start this role, it'll be good to start it with a problem in hand, so you know what you need to tackle. And most of this time, you need to involve with a lot of multidisciplinary groups, such as your doctors and your pediatrics. The role may change because your problem may change. So today I'm doing imaging and treatment review. Maybe tomorrow tackling something in, or the day after something in. So it's an ever-changing role. So we need to be very adaptive yourself, not just assessors. And then you need to have good relationship with the people in your department, because this change takes time and takes a lot of effort. You need the head and neck oncologist give the information that you give them. You need your physicist to support your planner, your dosimetrist to support you, because you'll be calling for simulation to add on to their workload. They need to believe that this is okay. If you are going to go in this role, you are not alone. It is a small group, but there is a community out there. So there is this worldwide community called the Isrrt-Rt-Rtt. So if we organize a conference every 2 years, so this conference is very specific. It's just on advanced practice, whether is it diagnostic imaging or is it RT. So we discuss things around the world, from Canada to US, Europe to Australia, whoever that's doing this role, share the knowledge and we'll share our difficulty and how do we overcome it, so that we do not need to relearn the same mistake. So the skill sets that you may need might be out of what you learned previously. Your training as an RT might not be sufficient in doing the job that you need. So you might need to learn from the physicists. You might need to learn from the head and neck radiation oncologist. So, for example, the Princess Margaret head and neck advanced practice person, he learned his contouring from the radiologist, not even from the oncologist. Learn from the expert, because they are the expert in reading the image. So they know this belongs to what organ or this belongs to the. So he learned his expertise from outside. Okay. Then, like I said, involve all aspects of the department. And lastly, you need to be very open-minded, because there are so many new things that we can do, so many new equipment or technology or processes that you can operate into your department. All this will help guide the goal that you're going to develop. Okay, thank you very much.
Much, Mr. Howanda, for very I think we are a little late, but we need one or two questions this session. Chắc chúng tôi cũng muốn một số ít thông tin về tiếng Việt trước, vì đa phần là chúng ta đây là sorry, I speak English for some. Ta có hai bài chúng tôi nghĩ là rất là hay. Bài đầu tiên là của ông Cash độ, thì chúng ta đã có những cái tiến bộ cố định trong đầu cổ rất là khó, và ông đã trình bày những cái loại mặt nạ khác nhau, cũng như là cái xạ trị đầu cổ đến xạ phẫu. Ngoài ra thì ông đã nói lên những cái thử thách như là cách để chúng ta khắc phục cái khó khăn trong về cố định cổ. Có nhiều cái thay đổi sụt cân hoặc là thay đổi vị trí dây phẫu, cũng như chúng ta phải làm lại xạ trị thích ứng. Qua cái bài thứ hai chúng tôi nghĩ cũng rất là hay, nó bổ sung như bài thứ nhất là cái vai trò của kỹ thuật viên. Thì, trong cái phần kết luận của ông Hồ Quanh Đa thì chúng ta thấy ở Singapore cái vai trò của kỹ thuật viên rất là rộng, không chỉ là cái việc mà thông thường chúng ta hay làm ở Việt Nam, ví dụ như là mô phỏng hoặc là xạ trị, mà quan tâm đến mức là cái vấn đề xử lý răng miệng cho bệnh nhân mổ răng cũng có thể tham gia, hoặc là làm việc với bác sĩ, làm việc với kỹ sư, và cũng như là tất cả những cái aspect, những cái mặt của trong khoa đó liên quan tham gia hết. Và cũng như ông Hồ có chia sẻ là chúng ta phải thay đổi chính mình, là adaptive của kỹ thuật viên phù hợp với hoàn cảnh, chứ không chỉ là cái
Đây những chia sẻ chúng tôi nghĩ rằng là rất là thiết thực cho vấn đề phát của ngành y tế Isrrt-Rt. Chắc có lẽ chúng ta có một hai câu hỏi mà chúng tôi nghĩ rằng kế bên chúng tôi là phó chủ tịch hội cũng rất có kinh nghiệm và cũng là làm một cái trung tâm ung thư quốc gia của trung tâm ung thư của bệnh viện đại học quốc gia Singapore đó. Tôi cũng có cái kinh nghiệm đó cũng rất là phát triển. Xin mời các bạn đồng nghiệp. Có câu hỏi này có thể nói tiếng Việt để chúng ta dịch ra tiếng Anh hoặc câu hỏi trực tiếp. Give the microphone for the audience.
And please let me know how you work in the one practice and neck practice. So may I ask a very simple question only because I'm very interested to know about the advanced practice. Even in Hong Kong, we are also practice the similar things, but we don't have the formal post like the advanced practice radiation therapy. But I would like to know if you are the head, you in charge for the head neck advanced practice, right? So how many case or how you select the head neck case to supervise, or all the head neck case you need to monitor the imaging? Because every day when we know every day the treatment have so many head neck case. So is it all the head neck case you need to go to the machine to observe their imaging? Is it or you have another selection, maybe some difficult case you will go to observe or any selection
Question. So this is a very true problem because head and neck has a lot of imaging. What I'm trying to do now is a bit ambitious. I'm trying to review all the head and neck combis, not on the spot, but offline. So we are still trying to empower the RT on the floor to make the decision. So based on the traffic light protocol, they should make the correct decision. That's the first layer. Mine is layer number 2. So I think it's like the first sieve. I'm the second sieve to make sure that based on the traffic light protocol, nothing is missing. Or based on my expertise, I feel that maybe this one needs to escalate further, which is not part of the protocol, which is okay, because the traffic light protocol is not supposed to catch 100%. It is probably going to catch maybe 90% of problem. The rest of the 10% is something that then will give me the opportunity to focus on my energy. So obviously, sometimes the doctor will already tell me I have a difficult case coming. Then of course, then I will take more notice of the patient and I will try to be there for the patient during the first day at least. But because like I said, there's many roles that I need to do. Sometimes I'm in other machine helping out, so I can't be there all the time. I will need to rely on my therapists on the floor do the job that they are supposed to do, and I will back up their decision with the offline image review as soon as possible. Normally, I will try to do it the same day, not the next day before the patient comes. So this is something that I try to do. Whether it's going to be sustainable, not sure yet, because I'm only one person. There's many head and neck patients. That is the thing that we are still trying to find out, because the model is not fixed yet. We are trying to define the model now. Once the study has concluded, then we will need the decision of the head and neck pathology side that yes, they agree that I will cover whole head and neck imaging. Or maybe they agree that I will cover everything except for the first day. So we have not decided that decision. And hence, once we firm that up, then the role will be more definite. Then the extent of how often I will see the more defined. Answer your question.
So from your experience, how many at one practice how did I mean the whole of the practice? How many of role do you think is suitable?
ideally, my ideal state, I feel that every site should have an advanced practice. At least one. At least one. My center is not very big. We only have 4 linear accelerators. So I think if every site has one advanced practice role, it will be good because I think then you have someone to focus on the site. What previously before we have this role, everyone is everything. So I treat from head and neck, thorax to abdomen. There is no focus. I can do everything, but everything is okay. So there is no focus. You can't bring it to the level. So once now I'm only focusing on the head and neck. I focus all my attention there. I can have more ideas and more incorporate more of the processes that I feel that is good for the head and neck. And I can leave the rest for my colleague who's going to develop the rest. So in NCCS, there are 5 advanced practice roles. So they have head and neck, lung, palliative, gynae, and breast. Yeah. So these are the 5 main ones that you see most of the. So with these 5, that covers probably 90% of your patients. So all these give them the expertise or the focus each particular site or processes, and that will help bring that site or process to the next level. Because if you do everything all the time, it will be very good, but you can't be better. You have no energy to focus on. But minimally, I think 1. If you have 2, of course, better, but then management have to support. That is always the thing because you need to always explain to the management what is the value that you bring to the. So with 1, you can bring a lot of value. 2, maybe the value, yeah, not so impactful. But of course, only 1, then also it's more tiring because everything is on. You need to drive the study, you need to drive the business. Then you need to tell your team, yes, believe in me because I've done this. You need to now make this into our standard. So the thing I learned from overseas is that the saying is the advance of today should be the standard of tomorrow. So every day you are advancing, you are bringing the new thing to. So now this becomes everything.
Xin mời làm luôn rep hay cần có thể là thời gian rồi buồn thì đúng. We would like to invite speakers and chairman to take the photo together for the first session.
the next section, we have three panelists here. First is Mr. Ho Quan Ta from Singapore. The second one is Dr. Nguyễn Minh Huệ from General Hospital, and me, Mr. Phan Ritten from FB Hospital. For this session, we have the three speakers for three presentations. First of all, I would like to invite Mr. Eric Yuan and Mr. Trapong Rêu. I don't know which one will be the main one. So both of you will, okay. Okay, click on my stage. We will start. You will have half an hour to your presentation. Okay. I will try to speak Vietnamese a little bit. Mình sẽ bắt đầu phiên thứ hai của buổi hội thảo ngày hôm nay. Và sẽ có ba chủ tọa đoàn, là một là ông Hoa Ta đến từ bệnh viện Thành phố Singapore, thứ hai là tiến sĩ bác sĩ Nguyễn Thị Minh Huệ, phó khoa phát trị của bệnh viện Chợ Rẫy, và tôi là Phan Đức Tính, là viên trưởng xạ trị bệnh viện FV. Thì bài báo cáo đầu tiên sẽ là đến từ bên phía Hồng Kông của ông Eric Yuan và ông Trapong Rêu về cái mặt gọi là thiết bị cố định trong xạ trị và thực hành của bệnh viện công lập tại Hồng Kông. Công việc sẽ có nửa tiếng. Xin thông báo đến hội trường là mình sẽ làm luôn, mình không có tea break, còn các anh chị cũng có thể tự lấy break trong quá trình mình nghe ha. Và mình sẽ dùng cơm trưa tại lầu 2 ngay căng tin. Mình sẽ sau hết tất cả mình sẽ lên dùng lên để ăn cơm nha. Xin cảm ơn. Okay, please.
Hi, good morning, everyone. I'm Eric, and I'm a radiation therapist from the Prince of Wales Hospital, which is a public hospital in Hong Kong. Today, I would like to say thank you again to invite me to have this sharing to all of you guys. Our topic today is the immobilization device in radiotherapy. First of all, I would like to reinforce the importance of different immobilization device in radiotherapy. First of all, the immobilization device can ensure the reproducibility when the patient positioning between the planning CT and also the treatment. Second, it can reduce the inter and also the intra-fractional movement, and this can minimize the geometric uncertainty. Furthermore, it can enable a smaller margin that's prescribed by the oncologist, which can spare the healthy tissue, that is the organ at risk, and also to deliver a higher prescribed dose to the target volume, the PTV. Last but not least, it is critical for some advanced technique like the SRT, SRS, or some SBRT, and this requires the sub-millimeter precision. Here's the content of our presentation. First of all, I will talk about different immobilization device. Second, I will talk about different immobilization device specified for different region. And then I would like to talk about different devices for different advanced technique. And then I will pass the time to Dragon to talk about some critical consideration during the choosing which type of the device. And then we would like to talk about something like the breathing control and also the bladder control. Here are the main material used that when we are doing the mode for the patient. First of all, we would like to use the thermoplastic material. This material is heat activated rigid plastic material that can mold to the patient contour. And it has different thickness and also different perforation. There's different size of the hole. And then we can choose for different region and also for different techniques. The second material is the thickened cushion, which is the blue black. This is in the corner. And this is the flexible bags that fill the many pins inside the bags. And then when we are doing the mold, the air will be evacuated, become a rigid mold. And it is reusable and adjustable. And the third one would be the polyurethane foam, and it consists of two components that will be expanded and also hardened around the patient. And this can create a very precise mold for the patient, but it's a single use only. For the head and neck case of the patient, we will mostly use the thermoplastic mask. And this is the golden standard for the conventional head and neck cases. It will be secured on a base plate on the treatment couch, And the host, the preparations can improve the patient comfort. That means they can breathe in or breathe out more comfortable. And also the mask will be even extends to the shoulder region if we need to, the treatment is extend for the neck region. And when we are doing this, we need to have some clinical consideration of around three main points. First one would be what precision that is required, and also what is the duration of the treatment, and also we need to take care about the patient comfort. And here's are the clinical workflow when doing the thermoplastic mask. First, we need to prepare the material used. We need to choose whether we just need to do the brain region or we need to do the head and the neck region. And second, we need to heat the thermoplastic sheets, and this will be demonstrated in the clinical session later in the afternoon session. We will put it either in the water bath or a heat oven. It is around 70 to 80 degrees Celsius. And then we will mold the thermoplastic glass onto the patient's body, and which is over their faces or shoulder region. But we need to hold it with just little minimal pressure. And then we need to secure the mask onto the face plate. And at last, we'll need to consider the position of the patient and also to ensure the comfort. And the whole process needs around 10 to 15 minutes for the setting up and also let the thermoplastic mask to cool down. And here are another setup of it. This is the frame-based immobilization device. It's usually for the stereotactic radiosurgery. And this is a intensive in nature because it's attached the pin directly to the skull to the patient. Thus, it can provide a very high accuracy to that. It can provide a submillimeter. That's around 0.3 to 0.5 millimeters. That's very high accuracy. But it's only single use because it's invasive nature. And we can make use also with the localizer force for the precise target with localization of it. But it's quite uncomfortable and it's needs the local anesthesia for the patient. And then there's another method that is non-invasive method. It's the frameless immobilization mask. This can also provide a high precision, but also it can be fractionated. That can be a SRS or SRT treatment. And it can provide 1 to 2 millimeter accuracy with the image guidance. And it's more comfortable than the frame base. And we will have integrated it with the image guidance, just like the onboard imaging, the etc., or even the service guide. And here's the table to summarize that the frame base and the frameless. The accuracy, the frame base will be more accurate. It can provide a submillimeter, but the patient comfort is not good because it's the anesthesia and invasive nature. So that it can only provide a single fraction only. The second setup time needs to be a longer time because it's more support from the neurologist or anesthesiologist. And also the image guidance for the frame base is less because it can make use of the localizer force for it. And then I will talk about the frequent fusion more. The frequent fusion, we can call it a Radlock. This blue bag is also frequently used for the thoracic, abdomen, and also the pelvis region. And this is a custom mold that's made for the patient during the CT, for the CT. And it can provide around 3 to 5 mm accuracy. And it can also cooperate with different arm position, such like the arms up around the vertex region, so that the beam can be put it inside the chest region. The arms can be spared. Here's are the steps for molding for the Radlock. And first, we need to choose a cushion size. We can have many a big size or a longer one or a shorter one. Just depends on different region. And then we can distribute the beams evenly before we do the molding. And then we'll position the patient on the Radlock, put it in the midline, and also teach them how to move their arm, their position. And then we will mold the cushion and the patient contours can with the midline alignment. Finally, we will evacuate the air inside the vest, and then it will become hardened and rigid mode. And then I would like to talk about this breastport mobilization device. It is a very commonly used for the breast and the chest wall radiotherapy. It is an angled carbon fiber board and with the arm support. And this has many adjustable items, such like the hand grips or the arm positioners. And we can change to different headrests also. And this device can accommodate different patients with different breast size and also different anatomies. And this device can also integrate it with the deep inspiration breath flow techniques also. For the setup consideration for this breastport, there's main 4 components. First, we can change the arm position. For the bilateral breast case, we may need to raise their both arms or just single appendici when this is the unilateral breast case. And also, we can change the breastport angle. The angle board can be adjustable. This typically we will choose around 10 to 15 degrees for the standard treatment. And then the headrest, we can choose a different Superman, like Superman A or Superman C, which is commonly used in our hospital. And then we need to record all the adjustable parameters because there are so many things that we can adjust for the breastport. And this can ensure the reproducible for the treatment session. And this is the upper cradle used for the pelvic immobilization. And this is the whole body upper cradle that's used in our hospital for the pelvic RT. And actually it contains of 2 components that can mix together and then it will expand and harden after some time. And it can create a precise for the whole body. And this patient's specific and during the whole course, we will use this mode for time. But the disadvantage is this cannot be corrected when it's become hardened because it will become very hard. It's different from the padlock. It's more easily adjustable. And here's the molding process. First of all, we will prepare a plastic bag of it, and then we will prepare some 2 materials, the material A and material B. And then we will mix these 2 components together, the material A and B, with the ratio around 1:1. This depends on the manufacturer. They will provide us the golden standard of golden ratio of it. Then we will put the mixture inside the plastic bag and then distribute it evenly in the bed. We will position the patient in a treatment position. Some will like arms on the chest or on the vertex. And this depends on the oncologist's request. The 5th one will need some time for the foam to fully expand and become hardened. It needs around 5 to 10 minutes. And then when the foam is finished, we'll trim some edges and then to label it with the patient identification. And then I will talk about the SBRT device, that's abdominal compressor. The abdominal compressor is some special immobilization device, mainly for the liver, the hepatocellular carcinoma HCC, or some upper abdomen lesion. It will apply the pressure onto the upper abdomen patient by the plates. And it can reduce the diaphragm around 5 to 10 millimeters. Depends on the patient's breathing pattern and their own and then we will also use it with the padlock when we are doing the treatment and see. And the pressure can be adjustable by the patient comfort and the breathing motion of the patient. And this can help the oncologist to use the margin to the treatment. These are the steps for the abdominal compressor. First, we need to assess the patient whether it's suitable for using the abdominal compressor and whether they need it. We would like to evaluate the patient's breathing pattern by the fluoroscopy, the VNet, or using the 4DC without the compression first. And then we would like to place the compression plate, which is around cm below the xiphoid process on the patient's body. And then we will adjust the optimal pressure as his patient feel comfortable, and also we can restrict the breathing pattern of the patient. And we need to verify the verification of the patients by using like fluoroscopy also or like a 4DC. And we would like to optimize the breathing pattern or the tumor location is within 1 cm. And then we need to record everything, the location, where is the locations of the place, and also how much has. And then there's another device, is active control device. The ABC system can immobilize patients' internal anatomy by controlling their breath flow. And this device will the mouthpiece to the patient, and the patient will breathe through that mouthpiece by the spirometer. And this system will monitor the patient respiratory volume real time. And the airflow will be temporarily stopped when we press the button when we have predetermined level of it. And the treatment delivery, we need to the patient breath hold process. And typically, the patient needs to have and breath hold for around 15 to 20 minutes. And for the patient used for the ABC, the active breathing control, use the patient with very good pulmonary function. That means that they need to have the lung function test, the ABC. And also, they can follow our instruction, and we need to talk about them how the ABC. Also, we need to consider where is the of this case, and also the amplitude. And this also can be assessed by the post. For the training session, that the patients familiar with our equipment, how to use the mouth, and then we need to let them to practice how to in and breathe out using our devices. And we need to determine which is the optimal breath hold level of it. And also, we need to teach them how to emergency this and this safety of. Finally, for the treatment consideration, we need to consider the reproducibility of it to ensure the patient can travel at the same level of it. And then we need to set up some coaching session for them before the treatment session. And that's the ABC. So the training session is very important for them. And then I will pass the time to Dragon to talk about different visualization device for different region.
Thank you for Eric. It's summarize to talking about the immobilization technique we used in our hospital. Now I'm going through the let's say you can say the summary table about the immobilization of different region of different molding. For the brain case, we normally use the thermoplastic mask and stereostatic frame. Just now, Eric mentioned in their slide. And some for head and neck case, like the NPC or larynx or another head and neck case, we will use the thermoplastic with shoulder immobilization. That means the plastic will pull down a bit to the shoulder region. To increase the stability, sometimes we will consider to add the dental bite for the block to provide the widget for the patient to limit his movement. And to the dental bite is when we molding it, we'll normally for the head and neck use. For the brain case, we seldom use the dental bite. For the thorax case, we will apply the wing board using the vacuum cushion. Sometimes, if the lung case is an SBRT technique, we will apply the respiratory management device like the ABC or RPM control. For the abdomen case, sometimes for the SBRT case, we are using just now the abdominal compressor to control the breathing movement, to limit the breathing movement for the patient. And some for the pelvic case, you can see just now I have a very big upper cradle mobilization cushion for using the whole body for immobile the whole body. But this cushion we only treat the pelvis region. But why we apply the whole body? Because of some experience of taking some OBI, some imaging, we found that we apply the whole body. The image quality is much better. That means the positioning is much So this is why we are using the upper cradle to the pelvic region. And the extremity, we normally use the thermoplastic and the vacuum bag to give some immobilization to the. So the criteria for the immobilization device is main focus is 4 point. It's a patient comfort, because if the patient is not feeling comfort, they will have the involuntary movement, and sometimes they will move along the during the treatment. It's like the inaccuracy of the treatment. And the second thing is reproducibility. The immobilization device, we need to make it consistent to reproduce the same positioning every time. And the third one is if we will consider the beam path consideration. Sometimes if the for the lung case, if the tumor is located in the center of the lung, maybe we need to use the ring board to the arm up position to let the radiation beam to EC to go through. This is one of the consideration. And the workflow efficiency. And see the setup, is it critical, or is it need a long time for the setup? If it need a very long time for the setup, it is not efficiency setup. For some prostate case and gynecological case, we have need the patient to do some bladder preparation. Sometimes we will ask the patient to drink the water before the treatment and before the CT scan is about 300 to 400 milliliter water before the treatment or before the CT scan. After that, our colleague will using some ultrasound or use the cone beam CT to verify the bladder volume. If the bladder volume is matched with the planning CT, and we will proceed the treatment. So some special technique we need the patient to for training, especially for the breathing control case. Even for the free breathing control technique, we will try to ask the patient to see the monitor to let them to know their breathing pattern. Try to minimize the very size variation in their breathing pattern. They have audio coaching for regular respiration pattern, and a visual feedback using monitor system, and some practice session before simulation CT, and ask the patient to focus on consistent amplitude and their frequency. For the breath hold technique, we need to determine the optimal breath hold level. So the patient need to practice to hold the breath around 15 to 20 seconds. So this is very important for the communication with the patient, and create some backup plan if the patient cannot bear with the 15 to 20 second breath hold, then we need to think about it, maybe use the normal breathing to replace the breath hold technique. So sometimes we need to do the coaching. Actually, most of the patient for the treatment control, we ask the patient to do the coaching. Before the simulation, before the CT simulation, we need to ask the patient to come earlier and teach them how to do the breath hold. The practice session with the device are same as the simulation. And before the first treatment, we will remind the patient to do again and to refresh their memory. We hope that this regular reinforcement throughout the treatment course. For the bowels preparation, if the patient is full of, the rectum is filled with the feces, this is not ideal for the treatment for the rectum case or prostate case. So we will ask the patient to provide a diet. We will provide the dietary guidance to maintain their regular bowel habits, and consider some medication like the Daucus for constipation-prone patient to make sure before every treatment or a CT scan have the rectum. And for the rectal cancer case, ask the patient to have a full bladder status and an empty rectum. All the requirement, we will document it in patient record. In the future, the immobilization device maybe the 3D printing is the most advanced technology. In our hospital, some of the very complicated region like the eye or some cases like radiotherapy, we need to do the eye shield. We sometimes will ask another department to do some 3D printing for us to making the mold to do this treatment. And very commonly for the service guide system, is also used for the immobilization for the patient during the treatment. And the adaptive system, MRI guided, I think later on, Gary will talking about the MRI guided adaptive therapy is also is highly important for the immobilization of the patient. So to conclude, to provide the accurate RT, the immobilization device is very important to provide the geometrical accuracy and allows for smaller margins, very healthy tissue, and facilitate implementation of advanced treatment techniques, and also require careful selection of appropriate device and protocol, and demands attention to the patient, preparation, comfort, and education. So this is all very important for the immobilization during the RT treatment. So this is the end of our presentation. Do you have any questions?
The end of the session. So now I present Dr. Trần Trung Kim, Chief of the Radiation Department, CIMAC Hospital, with his presentation, overview of cancer radiotherapy at University Medical CIMAC Hospital.
Kính chào chủ tọa đoàn và các quý vị đại biểu. Tôi là bác sĩ Trần Trung Kiên, trưởng khoa ung bướu bệnh viện Đại học Y Dược CIMAC. Hôm nay cũng xin báo cáo một cái bài tổng quan về công tác xạ trị ung thư tại bệnh viện Đại học Y Dược CIMAC. Khoa ung bướu bệnh viện Đại học Y Dược CIMAC thì được thành lập năm 2018, được xác định là một cái khoa mũi nhọn trong công tác điều trị của bệnh viện. Và kể từ năm 2020 thì khu vực xạ trị với được đưa vào sử dụng và hoàn thiện tất cả các mô thức điều trị ung thư và được bảo hiểm y tế chi trả đối với xạ trị năm 2022 và với các cái thuốc hóa trị vào năm 2023. Thì với trong khoa có 4 bác sĩ về chuyên khoa về ung thư, có 2 kỹ sư vật lý và 2 kỹ thuật viên xạ trị. Ngoài ra thì có cố vấn từ bệnh viện Isrrt-Rt và có các bác sĩ hợp tác, có 4 bác sĩ hợp tác là tham gia điều trị công tác xạ trị ở trong khoa. Với trang thiết bị đầy đủ, với có khu nội trú và khu pha chế hóa chất riêng, và đây là khu xạ trị của bệnh viện. Thì khoa cũng có cái sự hợp tác đối với các cái bệnh viện trong và ngoài nước, thường xuyên hội chẩn với các cái trung tâm lớn, ví dụ như bệnh viện Isrrt-Rt, bệnh viện Ung bướu, hoặc là các cái bệnh viện ở tại khu vực Đài Loan. Hàng ngày thì khu ngoại trú tiếp nhận khoảng 25 đến 35 bệnh nhân tới khám bệnh, và có khoảng khu nội trú cũng khoảng 30 đến 35 bệnh nhân. Và riêng cái khu xạ trị ung thư thì hàng ngày
bình quân có khoảng 30 bệnh nhân là có mặt ở khu xạ trị. Và khoa ung bướu là kể từ lúc thành lập và đến 2021 thì hoàn thiện tất cả các cái mô thức điều trị ung thư, từ phẫu thuật đến hóa trị, xạ trị và các cái điều trị nội tiết, điều trị đích. Đặc điểm của khoa là nằm trong bệnh viện đa khoa, cho nên là thụ hưởng được những cái trang thiết bị của việc chẩn đoán và điều trị như hệ thống MRI-CT hoặc là hệ thống xét nghiệm vân vân của bệnh viện. Và riêng khoa ung bướu thì có có phòng pha chế hóa chất riêng ở tại khoa dược, với sự đầu tư của bệnh viện là hệ thống máy xạ trị HCO. Thì khoa là từ năm 2020 là cái hệ thống này là hệ thống đầu tiên ở tại Việt Nam được đầu tư tại bệnh viện Đại học Y Dược Sinh Bắc. Cái đặc điểm nổi bật của cái hệ thống xạ trị này tức là bệnh nhân được xạ trị một cách nhanh chóng và với các cái hình ảnh xạ trị dễ dàng. Thì cái đặc điểm mà tốt nhất của cái hệ thống xạ trị và HCO đó là tất cả bệnh nhân là 100% đều là được thực hiện xạ trị dưới hướng dẫn hình ảnh. Thì sự nhanh chóng thể hiện đó là việc chụp về con nguyên CT là rất nhanh, chỉ có khoảng 15 giây. Và nếu mà chụp X-quang thì nó chỉ cỡ khoảng 7 giây thôi. Và với cái hệ thống khớp hình ảnh tự động, thì bệnh nhân khi mà vào xạ trị thì thời gian xạ trị sẽ được rút ngắn. Bình quân thì chút nữa sẽ trình bày về cái thời gian xạ trị, nhưng mà cái thời gian xạ trị của cái hệ thống máy xạ trị này là được khẳng định là khá là nhanh. Trên cái hệ thống xạ trị thì có 2 màn hình để phục vụ cho công tác xạ trị, là cho việc là đặt bệnh nhân được an toàn và chính xác. Và đó là một cái ưu điểm và để cho sự an toàn bệnh nhân được đặt lên vấn đề tối đa. Camera là quan sát thường xuyên, kể cả trước, trong và sau quá trình xạ trị. Hệ thống HCO thì sử dụng hệ thống phần mềm tích hợp đồng bộ Eclipse và ARIA. Và ở cái khu xạ trị thì hệ thống CT mô phỏng được tách biệt với hệ thống CT chẩn đoán, cho nên là cũng là một cái điều kiện thuận lợi cho bệnh nhân khi đến điều trị thì sẽ được nhanh chóng hơn, chờ đợi nhiều. Dùng hệ thống đảm bảo chất lượng của hãng IBA của Đức. Thì trong khoa là tất cả các hệ thống cố định bệnh nhân được trang bị đầy đủ, đích là đạt được sự chính xác cho bệnh nhân khi mà sử dụng chụp CT mô phỏng. Đồng nguyên bo của vú, rồi mặt nạ đầu cổ sử dụng của hãng Griffith đến từ Mỹ. Thì để hiện sự nhanh chóng của hệ thống xạ trị HCO thì trên cái slide mình đã được thể hiện. tức là với các cái hệ thống máy xạ trị khác, với cái tốc độ của MSC là 2,5 cm thì tốc độ quay của máy Halcyon là lên tới 5 cm, và cái tốc độ quay Halcyon là một vòng 1 phút đối với các cái hệ thống xạ trị khác, và đối với hệ thống Halcyon thì lên tới 4 chu kỳ trong 1 phút. Nếu mà ở thực hiện kỹ thuật VMAT thì một cung là trên 1 phút, thì hệ thống Halcyon là 2 cung. Chụp con pin CT lúc nãy mình có trình bày đó là rất nhanh chóng, chỉ khoảng 15 giây, và với X quang thì chỉ có 7 giây thôi. Có sử dụng hệ thống MLC 2 lớp gây tránh rò rỉ chùm tia. Hiện tại thì trong khoa là đang thực hiện 2 kỹ thuật xạ trị, đó là xạ trị 3D và IMIT, và số lượng bệnh nhân xạ trị ở khoa ung bướu bệnh viện Đại học Y Dược Sinh Bắc thì tăng lên từng năm. Bắt đầu triển khai từ năm 2021 với 19 bệnh nhân, nhưng tháng 9 năm 2025 thì số lượng bệnh nhân đến tháng 9 năm 2025 là 250 bệnh nhân, với số lượng chiết xạ là 4.857 chiết xạ. Ở khoa chúng tôi xạ trị tất cả các bệnh lý ung thư, chủ yếu là ung thư vú chiếm 34%, ung thư đầu cổ chiếm 15%, ung thư tiêu hóa như là thực quản hoặc là trực tràng chiếm khoảng 16%, còn lại là các ung thư khác. Kỹ thuật sử dụng là kỹ thuật điều biến liều là được sử dụng thường quy hơn, đến tới 98%. Đây là một cái nghiên cứu chúng tôi thực hiện để mà đánh giá để đặt bệnh trên máy Halcyon. Thì trung bình các cái giá trị được thể hiện ở trên slide. Với ung thư đầu cổ là chiều trái phải 0.112, với ung thư ở lồng ngực là 0.194, và ung thư vùng chậu cũng vậy. Còn với cái chiều trước sau là 0.135 đối với ung thư đầu cổ, 0.206 đối với ung thư lồng ngực, và ung thư cung chậu là cũng 0.195. Với chiều trước trên dưới thì cái đầu cổ là 0.07, cái lồng ngực 0.11, và cái cung chậu là 0.085. Với thời gian xạ nhanh chóng, thời gian xạ này là tôi tính từ lúc mà bệnh nhân vào đặt bệnh trên máy xạ đến lúc mà bệnh nhân rời khỏi cái bàn xạ, thì thời gian của ung thư vú là 14,4 phút, thời gian ung thư đầu cổ là 9,2 phút, và ung thư tiêu hóa là 11 phút. Các cái bệnh khác về trong giảm nhẹ là 9,5 phút. Thì tổng quan lại thì khoa ung bướu bệnh viện Đại học Y Dược Sinh Bắc là với cái hệ thống xạ trị hiện đại mạnh mẽ, với cái đội ngũ nhân lực có kinh nghiệm, và điều trị hầu như tất cả các cái bệnh lý ung thư. Và ở khoa chúng tôi thì sử dụng kỹ thuật IMIT là kỹ thuật chính yếu, và số lượng bệnh nhân xạ trị hàng ngày cũng đạt ở mức độ tương đối. Xin chân thành cảm ơn các quý vị.
To the end of the next, we would like to invite Mr. Joseph Lee and Mr. Gary Yip from the Sanitarium Hospital, Hong Kong, to present their presentation on immobilization of adaptive therapy, a private hospital practice in Hong Kong.
Okay, good morning, everybody, persons and fellow colleagues from Vietnam and all around the world. Today, I and Joseph are going to present the topic on the immobilization of adaptive therapy, a private hospital practice in Hong Kong. Here is the content of today's presentation. We would like to talk about the differences between the adaptive therapy and conventional radiation therapy, some aims of the immobilization, and we also share some clinical case of MRD-NET on the treatment of the prostate cancer, abdominal cancer, and proton therapy on the head and neck cancer. So in the traditional radiotherapy, targets and OARs are contoured. During the whole course of the RT, the tumor may be shrink, or a patient might lose weight, or other reason. It will introduce some dosimetric uncertainty throughout the whole course of the RT. So here is the schematic diagram to show the differences between the conventional radiation therapy and the adaptive radiation therapy. Conventional radiation therapy has no planned modification or so-called replan throughout the whole course of the treatment, but adaptive radiation therapy, there is planned modification during the whole course RT. This planned modification could be done intrafractionally, that means online, or interfractionally, that means offline adaptive. So just like what previous speakers say, the immobilization device should be able to facilitate to expose the treatment area and helps to maintain the treatment position throughout of the whole course of the treatment. So we need to consider the patient's comfort and also reproducibility. That means that it is easy setup and it can reproduce day-to-day treatment. So when we select the immobilization device, the material should be rigid so it can easy to reproduce patient comfort. And also we need to consider that this immobilization device material should be radiolucent. That means no causing any artifacts in the X-ray or CT images. Because my center have the MR simulator and MR-Linac, that's why we need to make sure all the immobilization device should be MR safe. That means that it can be put in the MR machine in any field strength. So let me move on to MR-Linac on the prostate adaptive therapy. So here is the setup of the prostate MR-Linac radiotherapy. The patient should be supine on the headrest with the rigid knee fix and fixed step. The hands holding the grip so that it can prevent any induction current created by the MR machine. Although we have such this kind of rigid setup, patient externally, but there are some things internal that would cause the dose uncertainty. So as you can see, the prostate is located in between the bladder and the rectum. It can be easily displaced by the different bladder filling or rectal filling. So we need the bladder control for this patient, for the patient on the treatment of the prostate cancer. We will use the bladder scan, ultrasound-based bladder scan to measure the bladder volume to achieve the comfortably full bladder status. And also we would ask the patient to empty their bowel before the treatment or also before the simulation. Furthermore, we will use the endorectal balloon to reduce the movements of the rectal peristalsis. This diagram shows how to put the endorectal balloon through anus to the rectum. Here is the sample on my hand. You can have a look in the later, in the afternoon session. So the rectal balloon should be together with the lubricant, KY jelly, and then insert into the rectum through the anus. After that, we will inflate the rectal balloon with the normal saline. Usually it's 70 to 90 ml of normal saline, and then it can enlarge and then try to immobilize or reduce the peristalsis movement of the rectum. So this diagram is the actual treatment position for the MR-Linac prostate treatment. So the patient is supine and hands grabbing the grip, knee on knee step, feet on feet step, comfortably full bladder. Empty the bowel treatment. Empty the bowel before the treatment, and we are using the endorectal balloon. So after setting up the patient, we would we would do series of the planning CT, also together of the planning MR. For the most of the time, we are treating the prostate cancer using the MR machine. We use the SBRT dose. Usually, it is 8 gray per fraction at 100% isodose level to the PTV, 2 fraction per week times 5, up to 40 gray, and then stop. So series of the planning CT and planning MR will be obtained at the CT simulator and MR simulator for the planning. CT is for the dose calculation accuracy, and the MR, because it can have the better visualization of the internal organs, so it is good for the contouring of the PTV and also the OARs. So at the treatment of the MR Linac, pre-treatment MR image will be done for online adaptive planning, which is including the image fusion between the pre-treatment MR image and the planning CT. And then also we need to do some recontouring of the targets or OARs if necessary. And then the planning computer would do the online optimization and dose calculation. And on the right side is the final DVH and the dose distribution of the final plan. The oncologist would review it. After we approve it, we will proceed the treatment. Since the time between the pre-treatment MR and the doctor approved the plan, still have some maybe 10 minutes time. So just before the beam on, we would do one more set of the MR image to make sure there is no deviation between the deviation of the position between the pre-treatment MR and the and during the and for the treatment. So let me move on to the MR Linac on the abdomen adaptive therapy. Here is the typical setup for the MR Linac adaptive therapy for the abdominal cancer. Usually, we would use the armrest, so the patient can arms up, resting on the armrest, and the knee resting on the knee rest. You just see the in between there is some there is a perspex plate that is our in-house made abdominal compression belts. So the plate is made up of the perspex, which is MR safe, and this belt indexed with the ruler and made up of the nylon. So make sure that it's MR safe. For treating abdominal targets, it's very challenging because the abdominal targets will be moved. Please press. This is my respiration. Will be moved during the because of the respiration. The targets will be displaced due to the respiratory movements. And because for example, upper abdomen, for example, say pancreas or say liver, the stomach feeling would be different. So so we will ask our patient to do fasting before the treatment and before the simulation. So after setting up the patient, it should be the patient in supine position, the arms overhead resting the armrest. We will ask the patient to have 2 to 4 hours for reproducing the stomach feeling between the treatment and the simulation. And the abdomen is tightened by using our in-house abdominal compression belts, AC belts, to limit the abdominal respiratory movements. But whether we use this AC belt, we would do one more step, that is the screening, MR screening. So just before the simulation, we will ask our patient to put onto the MR machine to do 3 series of the MR image. First series is the free breathing without wrapping the AC belt. The second one is doing the MR image just after wrapping the AC belt. Since the patient may feel fatigue, so we will do one more set 10 minutes after the wrapping up the AC belt. The doctor will review all the images to see whether we use the AC belts. So let me share a case of the MR linear of the abdomen adaptive radiotherapy by using MR linear. The patient, she is 76 years old woman, suffer from CA pancreas. The ITV is given by GTV plus 3 mm margin, and PTV is the CTV plus 3 mm margin. We use the T131 3D Ring XD spare this MR sequence to observe the tumor movements during the RT. And because of the adaptive therapy, we tend to use the SPRT prescription. That is 10 gray perfection at 100% isodose level, treat in alternate day times 5 up to 50 gray, and then stop. So just before we start the treatment, we will take a few minutes time to obtain the pre-treatment MR fused with the planning CT. If necessary, just like what prostate case, we would perform the recontouring of the targets and OARs, and then we will perform the online optimization and with this new structure sets. And on the right side is the DFH and the dose distribution of the final plan. Although we have online adaptive planning, this target is still moving throughout the treatment. So it is better to monitor the target movement throughout the session. So MR Linear has been equipped with the feature of comprehensive motion management that is called CMM. That means that MR image is acquired during the treatment. So if the target is outside the ITV, the radiation beam is off immediately, so that the target is only be treated when the target is inside the ITV. And this features is quite similar to the technique of gating. And now showing the moving clips of the this is just the fast forward motion. Oh, the picture is not like this because of the time limit. Okay. Okay. So if the target is really shifted outside the ITV, so the beam will stop quite often intrafractionally. But our MRE-net has the feature of the baseline shift. It can restore the target motion to be inside the gating envelope. That means in the ITV. How to do that? So the machine would make minor adjustment by using the new average position of targets to the daily adaptive plan. It can compensate the systematic shift if the patient is shifted. The MLC would just move, MLC leaves would move a few to the desired location to deliver the remaining dose. So the dose distribution, tracking image planes, and gating envelope will also be shifted according to the new average target position. So now I pass the time to Joseph to talk about the proton therapy on head and neck cancer.
So thank you, Gary. Good morning. It's my honor and thank you for the opportunity to share with you a photon therapy experience today. Gary and me are from Hong Kong Sanatorium and Hospital. This presentation will explore the principles and practical application of adaptive therapy in proton therapy treatment for head and neck cancer. We'll focus on the challenges of anatomical changes and the strategies we employ to maintain treatment position from the first day. These slides outline our standard adaptive workflow. Treatment is not a static process. We incorporate regular verification CT to access the accuracy of our delivered dose. At each of these points, we face a critical decision. Is the current plan still acceptable, or have anatomical changes rendering it unacceptable? If a plan is deemed unacceptable, we proceed with a modification. So this cyclic verification, evaluation, adaptation, and modification is essential for ensuring consistent dose delivery to the target while minimizing exposure to healthy tissues. In a separate study, we examined the contour change patterns in head and neck treatments. I found that significant change typically occurs around the 16th section. So we dedicate the third week to analyzing the contours using verification CT to address these changes effectively. Effective immobilization is a non-negotiable foundation of all high-precision radiotherapy. For head and neck treatments, it typically involves a mouthpipe, a customer headset, and other devices like these supports. The key objectives of our immobilization are first, rigidity and reproducibility to minimize day-to-day setup errors. And second, patient's comfort. Because a comfortable patient is more likely to maintain still throughout each infection. To make this discussion concrete, let's consider a patient case, a 35 years old female with nasopharyngeal carcinoma. As part of our standard preparation, was acquired both a planning CT and an MRI for optimal target delineation. A crucial and sometimes overlooked step is performed a clearance check before the first day of treatment. This ensures that our chosen immobilization devices work perfectly with this individual and anatomy, and that there was no unforeseeable issues with the setups. Despite our best efforts, patients often experience changes during treatment significantly, like significant weight loss in a common challenge in head and neck cases. This leads to two main problems: a displacement of the clinical target and an alternation of the patient's external body contour. In proton therapy, anatomical changes can have significant consequences, as shown in this depth dose diagram. However, proton offers a unique advantage due to the back piece. However, this also means that there is a sensitive to change in tissue density and depth. Even minor shift in anatomy can result in the planning dose being delivered to the wrong organ or location, leading to underdosing of the target or overdosing of critical structures. For example, if a patient lost weight, it can display the treatment target and other body contours. Introducing those uncertainties. These uncertainties is more pronounced with proton compared in photons. Looking at the depth dose curve, we can see the target is typically just a few minutes below the skin. Photon therapy generally operates at a low isodose level with the slower dose fall off, making it less sensitive to contour changes. In contrast, the maximum dose for photon occurs at the back piece, just a few millimeters from the surface, and exhibits a rapid dose fall off. This characteristics makes photon therapy particularly sensitive to changes in contour and depth. At our center, we utilize intensity modulated proton therapy, IMPT, which achieves a spread out of rapid with dose fall off. However, it remains very sensitive to contour changes. Here's a real work example of our adaptive process in action. The patient has shown good progress in radiation therapy until week 4. However, weight loss leads to contour change that significantly impact the dose delivered to the clinical target volume, CTV70. During the week of 4 verification scan, we observed that the coverage of the high dose region, V70, had dropped below our clinical goal of 95%, down from 99.33%. This decline was directly linked to the patient's weight loss, prompting the doctor to decide on treatment repair. In response, we create a new treatment plan and offline adaptive. This modified plan accounts for the changes in anatomy, restore those symmetry coverage, and ensure the continued safety and effectiveness of the treatment. We can learn variable lessons from the experience of other centers. Their findings and practice can help us refine our own approaches and improve patients' outcomes. Let's explore some key insights that have emerged from the adaptive process and treatment strategies. Different technologies and enable different adaptive strategies. For instance, with MR-Linac system for prostate and abdomen, online adaptive is possible, while the plan is re-optimized in real plan immediately before the daily treatment. In our context, the proton therapy for head and neck, we often use an offline approach. We identify a significant deviation on the replication scan and then adapt the plan for future affections. Both methods share the same goal, to correct for anatomical changes and maintain treatment integrity. Additionally, some centers utilize cone beam CT for adaptive planning. In one study involved 59 patients, researchers found that in interfectional variation in the tongue and tongue bases, they conduct that 5 mm margin was significant to cover the planning target volume, allowing to reduce margins and sparing more dose to organ at risk. In summary, successful adaptive therapy is built on a strong foundation of reproducibility, immunization, and attentive tracking. The key distinction is that conventional radiotherapy it delivers a fixed beam based on the internal anatomy. Adaptive radiotherapy acknowledges that anatomy change and use a feedback loop to modify the plan when necessary. We use various devices to manage the involuntary motions, and we use advanced imaging to know when to adapt. Embracing this adaptive philosophy is essential for realizing the full potential of highly conformed technique like photon therapy. I'd like to sincerely thank to the organization for their invitation and my colleagues at the Department of Radiotherapy for their contributions. The concepts discussed today are supported by a strong body of literature, a selection of which is provided here for your reference, and thank you for your attention.
Thank you very much for my presentation. You have a 10 minutes for Q&A, and then first, yeah, we are our program is intend to end at 11:15. Right now it's late, so we try to have the short question, and then we move to lunch in the second floor. I would like to announce this afternoon, after the one presentation of Mr. Rt-Rtt, we will have the practice session. Practice session will start at 1:30 to 4 p.m. Okay, we have totally we have a 60 audience to participate practice session. We split into groups for the practice. Okay, the announcement will be later. Now, I will try to talk in Vietnamese for the audience follow up. Do thời gian mình trễ, thành ra là mình sẽ có 10 phút để mà hỏi và trả lời. Sau đó mình sẽ di chuyển lên lầu 2, mình dùng cơm trưa. Và chiều nay mình sẽ có cái buổi thực tập là mặt nạ. Bắt đầu từ 1:30 cho tới 4 giờ. Mình sẽ chia làm 2 nhóm để thực tập. Thì trong quá trình thực tập làm mặt nạ, mọi người sẽ có tất cả có 20 cái mặt nạ để chúng ta thực tập. Và lưu ý rằng là sau khi thực tập xong sẽ có một cái buổi là thảo luận về cái quy trình thảo luận quy trình làm mặt nạ cũng như là quá trình làm. Có vấn đề gì không thì bên chuyên gia sẽ hỏi đáp và trả lời. Ok.
Maybe I'll start with one question for Mr. Gary. Yep. So you mentioned that for your MR-Linac, you also do MR simulation. Can I understand for the planning part is are you still doing another CT simulation for the patient for planning, or is a synthetic CT generated from the MR simulation for
fraction? So we still need to do the series of CT simulation because we need the electron density on 3 unit for the dose calculation, and because we have the MR SIM separate MR machine, but with flat couch. We will ask usual practice. We will ask the patient to do his scan first. Afterward, for example, let's say the prostate case, to ask the patient to empty the bladder again and bring the appropriate volume water, usually just like dragons enter 200 to 300 ml of water. But the most important thing is the ultrasound bladder scan to make sure the bladder volume is similar to the CT scan, and then we would perform the MR scan. Usually, in our normal practice we would perform T2 and also T1 sequence MR image. But if the doctors want some more, see whether the patient is okay or not to go that, because it's quite some time. So we'll do some more. I think we should three series of the MR image.
Gary is right. We are in ordinary workflow, we'll use both a CT and MR. And for prostate cases, we start with MR only treatment. So we have a synthetic CT. So because it is still in the trial phase, so I think later on we will start with MR only treatment without the CT for prostate cases and other applicable cases. Thank you.
For you, hang out with you see it's rain out in our event transfer from the electronic right? And I had question use the proton using this.
We have a photon specifically for the installation. So that can, for the robust error, we can minimize from 3% to 2%. So the accuracy of CT is utmost important for especially the proton treatment. That's why in the mid of this year, we start with the proton counting CT. I think it's quite new in well, yes, and we are the first to have the proton counting CT for simulation purpose only. So can I answer your question, because the density is very important in a proton area. Correct.
Using the very hard. So is the rapid of. So when using when the first why the proton.
Yes, and we can also find the beauty of the proton counting CT is that it can generate from 70 kV to 140. So we can delineate well, no matter in the soft tissue, we have a lower kV and then higher tissue, and then it can also rendering with the metallic substances, some removal from, such that we can have the better data from the patients. So to make sure the proton treatment as accurate as possible. We will name it as a robust. We will always name it as a robust calculation accuracy. So Normally it will be 3%, but now we drop to 2%. Even though 1%, but you know the change is dramatic. We drop down 1/3 of the unknown factors. And that's how we want to make the photon treatment as accurate as possible. That's why we invest for a photon counting system. Thank you.
Because that's it. Can be proton CT, and I know that's it. How to control for the proton.
Actually, we have a machinery. We have robust planning. This is a term usually we use in proton because there's motion change, and then, as I've mentioned, the density. Proton is really density sensitive, and that's why we have to pre-calculate in case there's a more motion changes or any contour change. We call it robust planning or robust uncertainties, and so we usually this figure, and then now I think we have we can say we have it like a 2%. Yes. Thank you.
We have to think about the CT proton. The proton use simulation. I am a little bit confused. Maybe some specialists here and maybe use proton for this SIP. Proton CT cannot, right?
Yes, can, but somehow the discrepancy or uncertainty is higher. So in normal CT, they use a scintillation technique, initialize the signal from the photon. But now they just capture directly the photon energy to have the signal. So that's why it can minimize the energy use and have a very good contrast. So we call it a photon counting CT.
It's photon counting CT,
Yes,
not
direct.
proton CT.
No.
Proton CT, right? Okay, we
You're
clarify
right.
on that.
Yes.
Thì các bạn biết rằng cái chuyển qua từ công nghệ từ photon sang proton nó là một cái bước rất là lớn, năng lượng dùng cho proton rất là nhiều. Thì bây giờ thế giới người ta họ sẽ đi theo một bước mà chúng ta làm đi mức năng lượng 10 đến 140 PV. Khi mà chúng ta làm cái mô phỏng của proton hay là hạt ngầm mô phỏng thì mức năng lượng từ 70 cho đến 250 mét, bạn biết rất lớn. Tuy nhiên đó là một trong những cái kết quả mà những cái nghiên cứu gần đây người ta đạt được là nó phân biệt giữa các cái mức nó gọi là electron density, có nghĩa là các cái mật độ electron rất ngắn và có thể là phân biệt rất là rõ ràng. Và cái điều này nó giúp cho cái việc là bác sĩ người ta họ sẽ phân biệt được cái khối u và các cái cơ quan rất rõ, nhiều khi còn hơn cả MRI mà. Đó là những cái công nghệ mới mà thế giới người ta đang nghiên cứu. Tuy nhiên là một trong cái bất lợi của photon CT hay là carbon CT dùng trong simulation là cái việc về công nghệ, cái công nghệ về xử lý nhiễu cũng như là công nghệ digital thì là rất khó để giải quyết bài toán đó. Hy vọng là trong những năm tới thì chúng ta có thể nghe được những công nghệ mới, để là những cái khuyên về những các sử dụng cái hạt nặng để làm CT không cho nó sẽ thêm.
The last question. For advanced radiotherapy, SBRT for pelvis cancer is maybe quite difficult for movement. So I want to ask the question, do you recommend the 40 CT before CT stimulation or check the movement of the organ? For the abdominal,
Abdominal one, we will usually do one more set of body CT so that the doctor will observe the internal organ movement, target movement, so that the doctor will give a suitable ITV for that. So during the planning CT session, we will we will do one more set of VCT.
One more sharing. Currently, we are using MR-Linac to deal with the soft tissues cancers. Because there is no bone, the soft tissue can easily visualize under MR. And in our MR, we just implement a motion control unit, so we can observe the MR during the treatment without radiation to the patient, and then accurately focus on the tumor. So for the ITV, actually, we are covering the whole motion and the location or displacement of the target. But when we are using MR-Linac, we will try to even minimize the margin we have to add during the ITV. So we will do an ITV, and in the same time, we will try to evaluate the displacement of the target to laser those to be delivered to nearby way out. So this is the way how we do, no matter in MR, conventional or such. So we have some motion control to capture. And ITV is a good way in case we have to cover all the target placement during the treatment.
We will close here, and we invite all the speaker and the panelists to the stage for group photo, and then we move to the second floor for lunch, and see you at the 1 p.m. here to start the next section. Okay. Thank you. Hello. Mình ổn định vô nha các anh chị. Để bắt đầu cho cái phiên chiều nay. Phiên chiều nay thì sẽ có là một bài của ông Rakesh đến từ Ấn Độ. Sau một bài của Ấn Độ sẽ là bài phần thực hành. Ở trong đây mình sẽ phải chia nhóm thực hành. Với số lượng đông như vậy chia nhóm ra. Một nhóm sẽ là chia 3 nhóm. Nhóm khoảng 20 người. Nói luôn một nhóm chút xíu nhờ Ngọc chắc phân nhóm anh Ngọc ơi nha. Phân nhóm ra, một nhóm sẽ là nhóm số 1 là sẽ làm trong cái mặt nạ trước, nhóm số 2 cũng là mặt nạ ngoài đây, làm cái với thiết bị mà cố định đầu. Nhóm số 3 sẽ ở ngoài đây bàn về cái protocol của cái vấn đề Isrrt. Hoặc là những câu hỏi khác nào thì bên phía các chuyên gia sẽ trả lời. Sau đó là mình sẽ xoay vòng lại. Cách làm là vậy. Okay, everyone. We'll start with the next session with the one more lecture from Mr. Rakesh from India, and then we move for the practice session. The practice session we have the 3 groups. One group we have the 20 people. The first group, the group number 1, will be inside the separation room. Group number 2 will be outside in the control room, and group number 3 we stay here for the discussion about some scenario or the Isrrt matching or some protocol like some special command. Okay. Now I will give the mic to the chairman. Today we have 2 chairmen for this session. First, I would like to introduce Mr. Trong Liu from Hong Kong, and the second one is Mr. Anh Tú from the Dong Nai Medical Physics from Lam Dong Hospital. Please.
Okay, it's good afternoon, everybody. Welcome back for the session. So now we have going on the next session. Let us to welcome the presenter, Mr. Rakesh. He is the Chief Radiation Therapist of the Department of Radiation Oncology in the Max Institute of Cancer Care, Max Super Specialist Hospitals, Saket in India. Let's have a warm welcome, Mr. Rakesh. Today, his presentation topic is evolution and good practice of immobilization in radiotherapy. Let's welcome Mr. Rakesh.
Good afternoon. I think everybody had a good lunch. Maybe you are feeling sleepy. But once again, I'm going to trouble you, all of you. Actually, this topic, and evolution in immobilization and patient setup in radiotherapy. So everybody, sometimes the people ask me, is there artificial intelligence in the in immobilization? I said no. There's a human intelligence in immobilization. Because every day you have to apply your brains, and you can use your brains and use your appropriate decisions to implement whatever the immobilizations, the facilities you have, accessories you have available in the department. You can utilize that. So how the evolution has taken, I have, it was a long lecture, but I have reduced it to a little bit for the timing. So what is the clinical aim of the radiotherapy? As we know, to maximize the therapeutic index by delivering the lethal doses of radiation to cancer cells, so increasing their chances of the survival. So in conventional radiotherapy, administration of lethal tumor dose has limitation due to the tolerance of the nearby healthy tissues and organ at risks that cannot be adequately excluded from the radiation field. So when you doing the radiation with the conventional, you have to be very careful, because in olden days there was no imaging technologies, no verification techniques, whatever used, no masks, nothing was available in those days. To achieve our goal, high degree of precision is required from mold room preparation to treatment delivery. Between the mold room preparation and treatment delivery, there are a lot of processes are involved in this, like acquisition of the image in the CT or in the conventional simulators, or in the, I started my career in 1983 So those days we are used that marker X-rays. So then from marker X-rays, we shifted the conventional simulators, from conventional simulators to CT simulators. Now we are using the fused image with the PET image and the MRI image. So technology has changed as there is a technological development in the field of radiation therapy. There is as well as the technological development in the field of imaging also. So we are utilizing and we are exploiting imaging field also in the radiotherapy. So any device that helps to establish and maintain the patient in a fixed, well-defined position from treatment to treatment over a course of radiotherapy, or prevent the patient from moving during a single treatment session is the crux of the immobilization. So our aim is that immobilization, that we should be able to establish and maintain the patient position in a fixed every day. So objective is to limit the patient movement, to reduce the probability of the positioning errors. Patient should be able to sustain position during treatment and on the CT or conventional simulators during the whole course of the treatment. Patient should be comfortable in position. It is not that we have using immobilization, but the patient is not comfortable. We have to take that also care. The patient should be comfortable. And the position should be reproduced on daily basis. Patients should be sustainable. Benefits, so a reduction in daily setup time, we can, because we don't have make any efforts when the reproducible image setup is. So a reduction in the daily treatment setup, reduction in patients' fear and worry. We need to be awake, alert, and cooperative. So it is that we have to be alert in terms of when we use the immobilization, that documentation should be properly. When we go to the patient in treatment room, we should read what are the documentation, what are the accessories to be used for a particular patient. So what are the characters of? So increase the accuracy, easy to use. These should be the characters of this immobilization. Easy to use, quick to set, comfortable to patients, desirable enough to withstand the entire course of treatment. The device should optimally position the patient so as to minimize the normal tissue complications. It should not obstruct path of the beam, because some of the devices, they come in the path of the beam, that immobilization should be avoided. Device or accessories be able that should be compatible on the CT simulator, compatible with the MRI and other treatment planning imaging. That means that if we are using immobilization, that it should not give the artifacts. And also in MRI, it should be compatible, the material should be compatible, and low density material has to be used to get the dosimetrical benefits also. Rigid and holds its shape over a time. It is not that you should have a spongy type of headrests that one day it is something and other day it is something. It should be rigid and hold the shape of the patient's head or body over a period of time. Cost consideration of the material is very important. And the necessary supply, that we have to find out that it should be like molds. If we are using that, we have a necessary supply in the department also. And the vendor should be locally available, so that if the material is exhausted, that we can ring them this, please send them, we can order for the material. So it is not that we are importing and waiting for days together to get the material. So some of the is a reusability of the this like backlogs, it can be used. We have to also think in those things. And there should be enough storage space, because we have what I have seen in the previous hospitals, there were less space, and even small punctures in the backlog, that it was the whole game was over. So now if we start the history of the immobilizations, so was right from after the Röntgen discovered X-rays, and after 2 years we have started the treatment. So not starting from that, we don't know what they were using. There's no, there is literature available and not too much we can substantial that one. So in early days, plastic head cups, which I'll show there, we call it a doggy dishes, and standardized neck rolls, masking tapes, not to move during the treatment was the instruction given to the patient. Hold the breath was given to the patient. These were the early days. Then when we entered in the 60s to 70s, skin markers were used, plaster of Paris, bite blocks, vacuum molded plastic masks, polyurethane foams molds used. And in the 80s, lasers, indexers, click molds, vacuum molds, base plates, head spout, thermoplastic molds, and Bill Thompson frames. These were came in the early, and it is continuous development. So these were the adhesive tapes. These tapes to discourage the movement, tapes across the patient's forehead were attached to the treatment side rails. The tapes were attached to that one during the treatment, and then next day we used to again put the tape, but we don't know the accuracy of that, how much accuracy. And straps with Velcro backing was done, padded and reversible, helps to keep the hand at side and feet together, and it was not a pain. These were these we call the this head cups is we call it a doggy box. These were used in the early days, and these were the wedge foams, the customized, made by the departments, self department, not by any companies. Use it and use it for the early days. And this is that knee rest. This was also by used customized by the hospitals in the early days. Provides means of facility for inter-treatment and setup reproducibility. And this was again this phone setup for treating particularly for the CSI cases and head cases. Again, it was developed by some of the hospitals in US in early days. So in 1960s, complete body support or helmet head casts were made of POP. You can see that baby is lying, that this cotton roll was dipped in the plaster of Paris and put on the wooden bed. They have made the wooden bed, and it was the baby was placed on this, so it was used for the CSI cases. Most used in children for cranial spine irradiation CNS cases. Plaster of Paris has historically been used in radiotherapy for immobilization, especially before the development of the modern. These were the early days. I have used that one in I think 84 to 86. For 3 years I used that. So cover the area with the cling. These are the plaster players. Film prevent the POP from sticking. Then POP cast or shells were molded directly on the patient's body, neck and neck, head, neck in the treatment. So what they used to do, they used to apply the Vaseline, this, and put like a gauze piece on the face firstly, and then apply the plaster of Paris. And clips were used, and the base plate was developed at hospital, and we used the clips to fix the place. But it was a very cumbersome. It took almost 3 to 4 hours to make this cast, and there are a lot of disadvantages we can discuss. So then you can see that made of perspex sheets. It forms a non-malleable material when mixed and allowed to set. So here this material required for POP bandage was perspex sheets. After making this mold for head and neck with perspex, in perspex sheet was used, and it was put on the one of the machines to heat up and take the shape of this one. You can see it down. And then plaster Paris was removed, and then this final the perspex this mold was made, and we used to cut the window so that there should not be skin reactions. So advantage was there's the effective fixation, close conformity between body and surface. Portals can be marked, windows may be cut, and it was compatible with CT and MRI. So difficult and cumbersome to make, relatively delicate, use rough handling may fracture. That if you if the rough handling would have broken and there was no option to do the process again. Expensive and cannot be reused again. So disadvantage of the POP, we can say the labor intensive and time consuming. Still, POP becomes rigid and fragile once dry. It can crack or break if mishandled. It was very heavy weight, discomfortable to the patient, and POP cannot be shaped or adjusted. If it becomes tight, it was very difficult for the patient. In some patient complained that it is discomfort, can't do anything. There was a limitation, and it was a dust hazardous POP. Powder generates dust during the preparation, which can irritate your eye and respiratory. Non-water, if it was maybe by chance, by mistake, the water falls on the after dried POP, then the POP gets damaged. Patient discomfort during setting. The heat released during the chemical setting process can cause mid burns or discomfort. POP is a non-biodegradable and over time and becomes flexible. So then alpha cradle, I think this Alex has in the morning changed it. So just I want to how the bag was open and spread the blue polyform bag was. So two chemical components, polyol and isolate are mixed and poured inside the bag. The mixture expands and produces 10 to 15 minutes. Forming a rigid formula. The result cradle is customized shape to the patient's body. The same cradle is used during each treatment session for positioning. So this was the this cradle shape we used to do, but I have not done too much, but just for I think few months I have done. So that vacuum, we are still using it. It is important and it's in lot of the cases. So vacuum bags are made of a durable nylon material. So vacuum, what is the vacuum pump air is pumped out and the balls come together to form a firm solid support. The cushion becomes an entirely rigid and comfortable mold of the patient's body. So this is how this is the pump we are using, give the shape here, and the result was this one. So advantage, radio translucent after treatment, the bags is recycled and used for others. Disadvantage, puncture is one of the fear, and it can tear, mishandled, and necessary to resume with the patients because there is no option. So that backlogs can be used in combination with like costs for the CSI cases. Be effective the CSI. So then compression is again but we at our center we have compression belts. We are using that one, and we are also using because sometimes one of the compression belts it was damaged by one person, and we are using this simple BP apparatus. We can also do under the cost. We can, and this is and we can see that area we have. That is after taking the fluoroscopy imaging. But a lot of the patients are still using. That is very big. Now, this is, as we know that the plastic mask we are using 70, and these are the different in the one that I have shown we are using. And these are the pelvic thermoplastic we are using this type of mask is 6.4 pelvic rest we are using. And then we have another this all-in-one solution where we in rust there are chances that There's a lot of neck movements that we have to move past that prevents the neck movement. We have the neck. And this is the what we call the leg separator, where we can use this one to separate the leg, and so that the leg, when the legs together, they can't put stick. And we have the different this base plates is taken for different indexing bars. We have this, for different cases, and from fix and in there while we are using for SRS case. So this is the all-in-one solution from the from Orbit Industries. We are using this one. It has good. We're working for the last 15 got good results, and we are not facing. But the only things after every 3 years we have to change it, and it's not possible. So these are the thermo this head masks, and this is the prone belly head mask. This knee rests, arm rest. We are using. This is in the morning. Now this one previously we used like shoulder retractor, but we are not using now. And these were the initial days we used to do in this thing, some cups and shoulder retractors, and this perspex headrests. But we are using the low density headrests because it has got a little bit more density as compared to the low density head. But these were the early days. This mask for pituitary adenoma, this setup. We can elevate the position of the patient's head. So these are the breast setups in early days. Now we are using that this one, all-in-one solution. So the armrest with 90-degree extension and treatment coach rotates 90-degree. Axis of the arm aligned with the axis of the gantry rotation, planning and regular size isocentric. These were the some of the casts, prone casts, breast casts. That window is being 16. So this is the breast setup for the prone positions. We have done some of the cases in the prone position in this way. Setup was created in our department, but now we are not using it. We used to do it in late 80s or early 90s. After that, we have stopped. Really used to have earlier. And this I have also used. This is a traditional ball blanket to fix the head position, and the patient recurrency head position is recorded according to the reference. But it was very difficult for the patients. And the early days, patients with the trouble breathing and cannot be placed in their comfortable position. They used to sit on the chairs, and the gantry was laterally focused on the thorax region. It was only for the lung regions or esophagus region. Patients were treated. And these are the what are the available material at. And for pediatric patients, the backlog and some of the pediatric patients, we make the mask and we decorate in our own way so that the patient, the pediatric patient, she's comfortable, so that we can have protection of them. After the treatment, we hand over. And this that for extremities, like we have developed at our own, so that we have used it for this three clamp head mask. We have used for this one, and again three clamp head mask for this hand pushing downstream. Here also we have used this backlog and base plate also, customize it. And for foot, you can see that we have used the 3-point head mask and fixed them so that we have developed our customized way for the extreme setups. And then head fixation is the early days. You can see how the head was fixed. Now now we have into the era of frameless. Okay, these are the frameless masks we have. We're using all the three masks here. First two are the from stereotactic. So considering for selecting a device, it should be cost, it should be convenience, accuracy, the identical position must be replaced day to day. Minimal time, right, for daily setup, it should be compatible either. And attenuation beam integrity must be maintained, and durability devices must be able to withstand the repeated use. So I thank you for attention. This is the
Thank you, Mr. Rakeskor, for your very informative and practical presentation. So before move on to the practicing session, we are willing for some of the questions from the audience. So do you have any questions?
May I ask one question? Is how about in India? How you train the staff to be how to do the mold? Any training provided to the staff? Any training to the staff to make the mold? Do you have any training to the RT staff to do the molding? Any training?
okay. Yeah, actually, the present center we are almost we have almost 14 RTTs at the chiefs, and then we have 2 more. Whenever the new journey comes, the first posting we put in them for the 2 months. 2 months. Mold room and CT simulator. 2 months continuously to learn the processes, to learn the protocols. Because once he or she learns the protocols, and first I think first 2 weeks is the observation. Just observe what your seniors are doing and follow their instructions. If you have some questions, you can ask me. First 2 weeks observation, and then another 6 weeks, or that they have to be a regular RTT. But any difficulties, they can ask your seniors facing this difficulty. And like for TBI cases, CSI cases, we don't allow them to do alone. If we allow them to do alone, that is a esophagus, lung, pelvic masks. Not head and neck mask, but only head mask. And no SRS masks. But we allow them after 6 months to go all the cases. And then second posting is chemotherapy. Lastly, we put the process.
If there are more questions, we may move to the practice session. Nếu mà không có câu hỏi nào khác, bây giờ mình sẽ qua phần vấn đề thực hành ha. Thì bắt đầu phân nhóm ra. Bây giờ như vậy thì trong hội trường này mình sẽ có tất cả là 8 hàng ghế. 8 hàng ghế thì mình sẽ chia ra 3 hàng ghế đầu này là một nhóm, 3 hàng ghế giữa một nhóm, và 2 hàng ghế này một nhóm. Mọi người đồng ý không ạ? Mình cho nó nhanh ha. Thì nhóm số 1 là bên này sẽ vô trong phòng mô phỏng bên trong ha. Nhóm số 2 sẽ ở nhóm số 2 có vẻ đông á. Đông thì có thể trẻ ra, có thể 2 hàng ghế này là một nhóm, còn 3 hàng ghế này là một nhóm nha. Mình sẽ là ở phòng ở ngoài đây. Nhóm số 3 sẽ ngồi tại chỗ. Nhóm số 3 ngồi tại chỗ để mà phía đây có thể là vấn đề là hướng dẫn, vấn đề là có là những cái protocol nào để làm vấn đề mô phỏng cũng như là cái quy trình Isrrt nha. Ok, vậy mình vẫn vậy mình thực hành ha. Okay. I just explain to you the group 1, group 2 and group 3. Okay. Yes. Group 3 we will stay here and discuss first and then we rotate. Okay. Okay. Oh, really? Oh, so, really? Okay. Khoan, bây giờ mình ngồi tại chỗ xíu, ông Ấn Độ cũng cần là giải thích trước cái vấn đề là mình. Rồi, ok. Ok, vậy thì mình đổi ra bây giờ nhóm 1 vô trong giùm nha. Nhóm 1 là trong phòng CT mô phỏng. Nhóm 2 ở ngoài đây nha. Nhóm 3 ngồi mình sẽ dồn vào đây. Nhóm 3 sẽ dồn vào đây để mà nói về cái quy trình của cái vấn đề là mô phỏng ở đây. Okay. You be in charge group 3, right? Okay. Over. The group 3 will stay here. Please check with group 3 will stay. Lên chụp giùm anh nha. Vô nhóm 1 đầu tiên giùm anh nha. Nhóm 1 trong phòng. Du là nhóm 2 đúng không? 2 đi anh. Nhóm 3 mình dồn lên nha. Nhóm 3 mình ngồi bên đây để còn mình bàn ha. Nếu mà trong trường hợp mình có những câu hỏi liên quan tới vấn đề mình làm mặt nạ cũng như là vấn đề là mình tư thế này nọ có thể là mình thảo luận nha. Đây là nhóm 3 phần discussion nhiều hơn. Ok. Ok, sinh viên mà làm người mẫu đâu rồi ạ? Sinh viên làm mẫu đâu rồi? Có 2 bạn, một bạn nam và một bạn nữ đâu ạ? One lady, one girl and one boy. Oh. Nhóm 3 mình đứng tập trung đây đi để mà còn nói về cái vấn đề là cái quy trình làm, cộng với là giải thích một vài cái liên quan tới vấn đề quá trình làm đây nè. Anh Độ sẽ giải thích cho mình ha.